It's a pleasure to welcome you all to the workshop on wellness, ethics, and leadership. As you all know, it's very rewarding to work in the cancer care continuum. However, the crisis has added a burden on both the patients and the healthcare providers. That's why we need to acknowledge this. And this workshop helps us deal with the new reality and how to address it. We have lined up excellent and extraordinary 17 speakers to address these topics that deal with this workshop priorities. So an important topic would be how to thrive in the health crisis and to provide tips on how to survive the burnout and provide balanced mental health. Also, it's very important to address career advancement and how life shouldn't stop with the crisis, and we need to keep pressing forward. Additionally, women's leadership is very important, and we need to acknowledge some barriers and try to break them and to look for opportunities to advance. That's why also we shared with you some journeys of successful breast surgeons and how they did it. And with all that also we provided some reflections to learn about how to know when to seek help. Additionally, with focused on some cancer care, we really wanted to highlight the importance of multidisciplinary cancer care in empowering both the healthcare providers and their patients. Also the importance of philanthropy and how gratitude is one way of healing. And we're gonna end that with discussing some ethical dilemmas in cancer care, with discussing topics such as screening mammography, when to start, patients' privacy and autonomy, and what happens in the chemotherapy suite and what are the ethical dilemmas facing the chemotherapy nurses. Please bring your questions at the end of the session. We will be answering them at the panel toward the end. And thank you very much and enjoy the session. Hello, it's a great pleasure to start the workshop with a very important session that I'm going to share with you right now with wonderful panel of speakers. It's thriving in healthcare crisis and surviving the burnout. As we know, we need to acknowledge that we have been through a healthcare crisis and we have to navigate our way through it, even with heavy hearts, to ensure that our healthcare professionals are keeping their well-being and reclaiming their balanced mental health. We need to have some tips about surviving the burnout, and this is what our colleagues are going to present to us through their personal, professional experiences and organizational experiences, and some innovative way on how to really get through this crisis and survive the burnout. So thank you very much. We're going to get started.
So thank you so much, Rola, for having me here. I'm so delighted, and thanks to all of those who are calling in. So let's spend a couple minutes just talking about some statistics, right? Here's a survey of 300 healthcare workers and 200 first responders. They looked at COVID-related occupational stressors. They found 38% reported post-traumatic stress syndrome, 74% depression, 75% had anxiety, and 15% reported recent thoughts of suicide and self-harm. So this is really an issue. Here's a larger survey, 21,000 healthcare workers. They looked at a 6-month period, 38% with anxiety or depression, 43% with work overload, 49% with burnout. Not surprising, women had higher rates than men, and not surprising, those that felt valued in their workplace had lower rates of burnout. And this will be important as I talk a little bit later. This is a study in Ontario where they looked at burnout in hospital-based healthcare workers, and they found pre-pandemic, it was 20 to 40%, and then post-pandemic in the spring of 2021, this bumped up to 60%. Again, COVID has caused us to be more stressed related in burnout. And they point out, which I want to take a moment to also point out, I'm spending time talking about individual level interventions because that's what I was asked to do. You will hear about organizational level interventions later today, but we really need both to make this successful and for us to tackle burnout and address these stressors. So what is burnout? There's lots of definitions out there, but this is one by the WHO, the World Health Organization, where they say it's an occupational phenomenon. It's a syndrome resulting from chronic workplace stress that has not been successfully managed, right? So we have higher levels of stress with COVID. We're not able to manage it. We have higher rates of burnout. They talk about 3 dimensions of burnout, which I think most people are familiar with, but if not, there's the first stage, which is the emotional exhaustion. You're just feeling drained and tired, which leads to depersonalization, where you're almost numb. You're just emotionally distanced. And then it goes to reduced professional efficacy. So let's talk about some other words, resilience, right? And I'm going to spend some time talking about that and how we can build resilience. So resilience is the capability of recovering quickly from failure, and not just recovering to your baseline, but actually taking what you learned from that failure and using it as an opportunity to grow professionally and personally. And so resilient people are able to manage stress more effectively, so they're not overwhelmed, and this helps them address burnout. People who find meaning in their workplace tend to be more resilient, tend to have lesser burnout. They feel like they're part of something bigger, and I'll talk a little bit more about that later. And most importantly, resilience is not, oh, I was born with it. Resilience is something that can be learned, that can be built upon, that can be developed. And so we all need to work towards building this resilience. And I'm going to take it a step further, because a lot of people talk about mindfulness. So this is the Webster Dictionary definition of mindfulness, which is the practice of maintaining a non-judgmental state of heightened or complete awareness of one's thoughts, emotions, experiences on a moment-to-moment basis. A lot of words, right? What does that mean? It really means what this picture reflects. We should always be here. If you're always here, you're mindful, right? You're looking at the trees and the sun, you're focusing on the trees and the sun hitting your face and how beautiful the trees are. Quite frequently, we are here, right? In the chaos of everything else that's going on around us or in the back of our mind. And so how can we be more mindful? It'll help us with burnout. So here are my top 10 tips or rules that I live by that I'm going to share with you. And I think that if you can live by these rules or use these tips, this will help you thrive and avoid burnout. So rule number 1, take care of yourself, right? You can't pour from an empty cup. So make sure your cup is full, whatever it is, to refuel and re-energize. So those are the basic things of eating well and sleeping, but there are also things that make you feel good. Whether it's exercise or meditation or yoga or knitting or connecting with friends or cooking or whatever it is that's going to fill your cup. Make sure your cup is full, because otherwise you can't share with others. Rule number 2, identify your larger purpose. So I recently switched jobs after more than 2 decades of being at the same institution. And I took 3 months off. And during that time, I really used that time to identify my larger purpose, right? What's my true north? What is the mark I want to leave on the world? Sometimes we get so busy and doing, that we lose sight of that focus. And it's really important, if you don't know your focus, that you take the time to identify it. And this concept of something bigger than yourself is really important, right? To give life meaning, one must have a purpose larger than self. Rule number 3, enhance your sense of belonging. We all need to feel like we belong. And we have had an issue with COVID, because COVID has isolated us, and that, I think, has contributed to this higher rate of burnout. So find different ways to connect with family and friends and colleagues and patients and community. Technology is not great in some ways, which I'll share later, but is also great in other ways. I've seen my friend Rola more probably these last 2 years than in the 5 years before, because we're not in the same state, but Zoom has allowed us to connect with each other. I have the opportunity to speak to you today and the privilege to share my information with you today because of this different way of connecting and belonging. Also, surround yourself by those that support you. Don't allow anyone to diminish your self-worth, right? There are people that support you and the people that don't. Minimize the negativity, focus on the positivity. Rule number 4, have a low threshold for gratitude. Say thank you. And at the end of the day, and I tell my kids, and I do this myself, Think of 3 things that you're grateful for today, 3 good things that happen, and they can be small. They could be the sunrise that you saw in the morning as you were driving to work. They could be the thank you that a patient told you. They could be the dinner that you had with your family, whatever it is. Gratitude is not only the greatest virtue, but the parent of all others. So I talked about how technology is helpful, but I think we've sort of shifted the pendulum to the other way. It's too much. We're Zooming, we're phoning, we're emailing. So make sure you build in time that's technology free. You know, don't have your phone at dinner. Don't sleep with your phone and check it before you go to bed and check it the first thing in the morning. Disconnect and allow time to be technology free. And if you can, build in some days in your schedule, once a month, once every 2 months, where you're tech free. And this will allow you to do rule number 7, which is connect with nature. This is a place, there's a hike in Vermont. We have a place in Vermont, and this is a pond at the top of the hike. And we go there, but you don't really need to travel, right? There's nature all around us. So really, again, living in the moment, seeing the trees and the sunset, and being mindful will allow us to reground. Accept imperfection. We're not perfect. We're overachievers. We want to be perfect. We try to be perfect, but failure is okay, and failure will happen. And remember, we learn from failure more than we do from successes. Sometimes failure will allow you to be more resilient and will help you address burnout. And we're often willing to forgive others, but also be willing to forgive yourself. Rule number 9, don't be afraid to ask for help. Right? We try to do things by ourselves. I'm a very confident, independent person. I grew up that way. But we tell our children, right? It's okay to ask for help, and you should take that same advice. There are people around you, there are resources available. Sometimes we try to do everything right, but we find ourselves in a dark place. And so ask for help when you find yourself in that place. And lastly, rule or mantra number 10, we are stronger together than we are alone, right? And this sort of ties everything together in terms of having a larger purpose, in terms of having a true north, and in terms of working together. I think COVID has impacted us negatively in some ways, but it has also brought us together in ways that I think a pandemic would not. And it's brought out some of the good things in people. And so really trying to focus on that positive energy will allow us to avoid burnout. So I hope that this has been helpful. I've been so delighted to be here today, and please feel free to reach out. I hope to connect with you again soon. Thank you, Rola.
Thank you so much, Tejas. This is such a great positive start for this. And again, great tips as always. And I know you live by them. So thank you so much. Moving on to the next talk.
Thank you. It is a real pleasure to be joining you. My name again is Christina Murphy, and I'm going to be talking a little bit about my organizational and personal experience as a Director of Medical Affairs at Peterborough Regional Health Centre during this crisis. Just for a little context, we are a large community hospital serving a large area with 500 beds and over 85,000 emerge visits per year. The group of credentialed doctors and professional staff that we support here in medical affairs is close to 500. And like most of the world, we've been through 5 pandemic waves with close to just over 5,000 deaths in our area, 5 hospital level outbreaks, with a real emphasis on critical staffing shortages, certainly during the Omicron wave. And we've also been a rescue hospital for COVID positive transfers from other provinces and other regions. Most of us know and have heard about this definition from the National Academy of Medicine. Burnout, again, it is a syndrome, and it's characterized by a high degree of emotional exhaustion and depersonalization and a low sense of personal accomplishment at work. And I think we know it is a clinical syndrome, and it can have serious and wide-ranging consequences. In my role of determining how as an organization we can support individuals to prevent burnout and to find joy at work again, I always find it helpful to think about humans as having energy accounts. And this is a concept that was coined by Dyke Drummond and published long before the pandemic. But the idea is that we withdraw energy from our accounts for the activities of our life and work. And we deposit energy during times of rest and rebalance. And burnout occurs when there's a negative balance over a long period of time. And really, a physician and any health professional's best work and best life depends on the ability to manage these energy levels. And we do have, as humans, 3 types of accounts, they say: physical, emotional, and spiritual. And depleting these accounts can happen at work based on a number of workplace stressors and factors when people experience things like a lack of control and autonomy, excessive workloads, inefficient processes, poor organizational support, and issues with leadership culture, when they have difficulty finding meaning in their work, and when there are serious work-home conflicts. And so how did I and the team that I work with really try to approach, as hospital leaders, strategies to help our staff manage their energy accounts, and in particular physicians? What did we do to help prevent, or at least do our part? And I think there are 5 things that are important from an organizational perspective. One, and probably the most important, and this applies in any crisis, is to listen to, communicate regularly and transparently with staff and physicians to enhance a culture of trust and to prioritize their safety. And we did this by having regular town halls, by encouraging people to speak up about their concerns, by very regularly sharing data and updates in situation reports, being open and honest about our uncertainty about what was happening and what we should be doing, and inviting really 2-way communication and open idea sharing from everybody. The other important thing is being very visible in the areas where work was happening, where clinicians were actually working, and leaders being visible and being talking to them and being open to ideas and concerns without judgment and without necessarily solving every problem at the time, simply listening. Second was activating our outreach-based peer support program. Our peer support program is based on the model used at, coined by Joe Shapiro and used at Brigham and Women's. And this was important. We had developed this, but the pandemic really allowed us to activate this further. And we know that oftentimes, physicians do experience isolation after serious adverse events or in any crisis, and that physicians really do benefit from outreach from peers. And we have a group of 20 trained peer supporters. And during the pandemic, these trained peer supporters did active reach out to their peers and colleagues to ask them if they wanted to connect by phone or to send a text or to let them know that they're thinking about them, without requiring the individual to request support, because we know individuals, especially clinicians, don't often ask for support. And then there were other tangible things we did, providing easy access to scrubs and other PPE, paying for parking, and also throughout the organization having wellness and decompression spaces where individuals could take off most of their PPE and could just be and have some quiet time to themselves. The third is, which is very important, and it speaks to the importance of autonomy and being able to shape what you do in your role, is that we engaged physicians in actively shaping how they would work and what they would do, and in trying out protocols, and then provided strong leadership support to prepare for really difficult ethical prioritization of resources if we needed to do that. So they had the leadership support to do the very tough and difficult ethical things, but also were able to shape how things looked. And many individuals stepped up to do this, and we were there to support them through it. The other piece from an organizational perspective was to recognize and thank professional staff in safe but meaningful ways and celebrate milestones. So, throughout the pandemic, there were so many difficult moments, but there were good moments when we discharged, some of our sickest patients who recovered, and really thanking people in ways that were we still had our recognition event, which we have every year, but we had it virtually. We had baskets delivered to all of the professional staff home so that they could enjoy them with their family, but also be together virtually during a recognition ceremony. Finally, really trying to remove administrative barriers and create some flexibility in how people worked throughout the pandemic. And so we did this by really facilitating a rapid and efficient transition to working differently. Things like moving to virtual care, helping people with the technology, helping them make it easy to do the next thing rather than increasing the administrative burden. Really, the goal was to help clinicians actually provide patient care in the safest and best way they could. So that's hospital leadership strategies in terms of being able to manage those energy accounts and what we did. Just showing you here on the left-hand side, my left-hand side, you can see we had close to 200 physicians participate in our recognition event, and you can see all of the screens and the individuals coming together one Friday evening last year, and a heartfelt thank you that we shared with our physicians. We did this publicly and also internally in the organization. In addition to organizational strategies, there are also individual strategies around managing your energy accounts and reducing burnout. One of them is around, control and doing something about what you can control. And so really those individuals who actively engaged in helping to do something, to develop, test, and improve protocols, to come up with innovative practices in the midst of uncertainty, really helped to manage their energy, to not let it deplete, to stay positive. The second was really building that sense of individual purpose and of also community. So we did have individuals, several family physicians from the community who at that time didn't have privileges at the hospital, stepped up to do different work, to open our assessment center, to help with vaccine clinics. We had individuals help to provide ICU support who weren't ICU physicians. And so doing something, building that sense of purpose at a time when many groups struggled with their sense of purpose, given that some of their work stopped, really did help. Individuals who actually got help, asked for help, leveraged the resources offered to reduce those work-home stresses and conflicts, people who made use of the city organized childcare, we had groups of physicians who shared childcare at home, who used housing at our local university for times of self-isolation in order to keep everybody at home safe. And there are many other resources that people used. We also had groups that embraced mindfulness meditation, or individuals that really made a very serious commitment to rest, exercise, and nutrition during this period. And we found that some of this really helped significantly at an individual level in terms of depositing back into those energy accounts. And the other important thing is finding alternate ways to maintain social connections and to allow time and space to be human and share emotions. And I'll share something where at the end of shifts, people did, once we were sort of into the pandemic, take some time to debrief after a shift together and to hold some space for sharing emotions. The other thing I'll add here is we did have a number of professional staff who learned and did something new, a new hobby, or reconnected with something important to them that was completely different from supporting the crisis on the ground, whether it was art or mountain biking or something else. They reconnected or learned something new. And so just an example here of we held virtual mindfulness sessions to really focused on professional staff, and we had a series of 4. The going home checklist is really about holding time and space for emotions. And these are posted on the exits of many clinical areas. And really, there was a deliberate approach to check in with individuals and to really go through this checklist to take a moment, think about the day, to acknowledge one thing that was difficult and try to let it go, to be proud of the care, to consider 3 things that went well, to check in with each other, to check in if they're okay, to know that they're not alone, and to turn their attention to home. And then we also really supported individuals to connect with some mindfulness meditation apps. And on Doctor's Day last year, we did pay for a number of physicians as part of a draw to have a year subscription to Headspace, for example, and there are other apps like Calm. So just, to close out, I talked a lot about, managing the accounts, what to avoid in any crisis as individuals and organizations in terms of depleting the accounts and really leading to burnout. Organizations really need to avoid fostering and modeling a culture of silence or lacking mechanisms to hear and respond and value feedback and have leaders that are not visible. Creating inflexible work arrangements and discouraging innovation is a problem and is extremely important to avoid in order to ensure that our people don't burn out. Placing administrative burdens on clinicians and without engaging clinicians in shaping their work, and deprioritizing funding and support for personal and professional wellness and physical and psychological safety. So when money comes before people, it's a problem. For individuals that where they found that they were burning out significantly, we sometimes see that they're sort of avoiding asking for help, or potentially really, sort of ruminating, blaming others in the organization, and not being able to speak up or suggest solutions. Resisting participating or trying new ways of working and fueling conflicts, spiraling on social media. Social media is helpful, but at times it can be harmful, and really deprioritizing their own personal well-being. And those have impacts, as we know, on relationships, sense of purpose, physical, emotional, and spiritual health. Thank you.
Thank you so much, Christina, for sharing all these important insights and tips. As they say, history repeats itself. Just like other crises in the past have passed, this shall pass. However, we don't know what the new norm would be like, but definitely it will pass. And thank you for giving us some tools to navigate through it. We're moving on to Dr. Carol Wiebe. Carol, you have the stage.
Surviving and thriving. We have very similar titles because wellness, I think we've all felt the doldrums of the pandemic. It's not just been devastatingly difficult, but it's also been numbing. So I think finding ways to thrive have been is key. Just to give you a quick introduction, I've always been the doc who's been invited to be on wellness committees and to teach wellness to the medical students because I've been seen as being well balanced. I need to learn wellness in the pandemic just as much as anybody else. But that history of staying healthy with marathons, being balanced with being a mother, always bringing some music, hosting house concerts. So people thought, oh, she must have her stuff together. Not necessarily. I was VP for Medical Affairs. So there's a medical affairs theme going through this at Bruyere in Ottawa. We're a large academic hospital with 2 hospital sites, 2 long-term care sites, 2 family medicine sites. So it was a big job, and it was made very difficult with the pandemic as infection prevention and control was under my portfolio as well. I got that job, I think, initially just because I stayed in one place for too long and I did my job well. But I didn't have the qualifications. So I was looking around for an MBA that would give me it would have some emphasis on healthcare and the life sciences, and started that together with Rola in October 2019. So the pandemic hit, had a busy job, was a full-time student. Life was stressful. It was busy. But then it was made worse with a bit of a personal crisis where kind of a falling out in the relationship with my boss. And I think being seen as being not trustworthy had me restructured out as VP. This was personally very difficult. I was very thankful for the peer network at the MBA and for family and friends, but ultimately saw that gift of time as an opportunity. I really wanted to find something that would help me make a difference, bring together my skills in music and medicine and leadership, and be fun as well. So after, I had lots and lots of meetings with friends, with advisors, a group of women I called the Wise Women. We met regularly by Zoom every Friday. And also it became my capstone as the MBA. And I launched together with an artist who had done the Artist in Residence program at Bruyere. We launched Radical Connections in August of 2021, knowing that the arts are actually really crucial to improving patient and resident experience in healthcare, but also contributing to wellness and humanity for staff and physicians. I'm not going to repeat what Christina said, but it's just the stats are really bad. Even before the pandemic, severe burnout in healthcare, this was surveying nurses and doctors, was 20 to 40%. And now it's over 60%. There's a book I recently read by Dr. Gillian Horton called We Are All Perfectly Fine, which highlights that we are not. And there are evidence-based interventions. Christina's gone through a lot of those. Those organizational interventions that she described, research shows that they have greater impact and they are more sustained than the individual interventions that we hear so much about. We all know those help. Exercise, mindfulness, diet, all of those things help. I want to focus on two things that aren't spoken about as much that have personally made a big difference for me. In 2021 at the start, I thought, this year I actually need to make some good New Year's resolutions because I need something to help me. And I hadn't been practicing piano. Life had been too busy, but I decided that needed to be a priority. I needed to set aside an hour every morning. And I had some specific goals that I wanted to learn and memorize 2 pieces. And I just sat at the piano and worked at it for an hour every morning. Not knowing at the time how important that was. I came to that because I listened to an inside voice. It was disciplined, completely absorbing work. And while I was doing that, I experienced aha moments and the wonder of breakthroughs. So it was a window to spirituality, which was a connection with something greater than me. That one, it's been highlighted to me recently with the research and the writing of Dr. Lisa Miller, that there's a science to this. Spirituality was probably something I avoided, having left a religious background as a kid and seen a lot of the spirituality movements as being kind of flaky. It wasn't something that I quickly embraced, but I think it's something that we all need. We need to find our own way to both heighten our awareness of the greater, that greater awareness around us as well as our connection to it. And for me, that was with that daily ritual and practice of practicing the piano. There is evidence for less depression, less anxiety, less substance abuse, and there is more grit and resilience, optimism, and tenacity. So personally, I found that important, but I also found that I wanted a way to contribute to making that easier for other people to access. And this is where Radical Connections came in. The artist that I've co-founded this with, CJ Fleury, I don't think I know a more playful person. And she brought that when she was working at Bruyere. This is a picture of our first pilot. And it was so funny. We were all gathering with the communications department to take pictures. She pops out these little birthday caps with polka dots on them. And the joy and the playfulness that brought, and that picture is actually, it's our homepage for Radical Connections as well. It became, there was real art that was ended up with this mural that honored the patients and the families and the staff that were involved in that mural. That's still there. That's a lasting reminder, and adds a sense of community to that unit where that was. But there was such this joyful playfulness. Playfulness has many benefits. We have to actually consciously, a lot of us don't naturally do this. Even myself, sometimes I forget, and there are some things that make it, actually Christina mentioned some of these too. Learning something new, often that's a way to be playful. You could do a home video, go for a hike in the woods, a new place. So it's bringing something challenging and novel in a different way than usual. Just letting yourself, both challenging yourself as well as getting you away from the daily difficult stuff by doing something differently. So Radical Connections, it was birthed in August 2021. We had this playful celebratory launch with Arts Network Ottawa, and we are bringing that just by bringing artists into healthcare. They themselves are the most playful spiritual characters I know, and they reach out and they connect with people in healthcare. So we're promoting virtual performances, storytelling, mentoring for both students in medicine, as well as the arts. We're linked with the Music and Health Research Institute in Ottawa, doing wellness workshops. Co-curation of art is when patients, together with artists, decide what goes up in the walls and how artists and residents should have spaces that are both spiritual, but also bringing in that love of art, which promotes conversation and connection between staff and patients and residents. So I hope this has been helpful. It really is something that's made a difference for me, and I encourage you all to bring more spirituality as well as playfulness into your daily life and work.
Thank you so much, Carol. This is amazing. And I really appreciate sharing your own personal experience and view on how to overcome burnout. With that, we come to the end of this wonderful session. I'd like to thank the speakers for their inputs and insights, and more to come in the reflections and questions and answers session. Thank you very much. Hello, it's a pleasure to start this wonderful session on career advancement, Keep Pressing Forward, by Katie Armstrong. She's a senior consultant and career and leadership development at the Global Executive MBA programs at Rotman School of Management at University of Toronto in Canada. Katie, it's a pleasure to have you here, so please go ahead.
Well, hello, and I am so thrilled to be here. So thank you so much for inviting me. So today I'm going to speak about career advancement. Now, career advancement is actually, there is a lot to talk about when we talk about managing our career and advancing our career. So I'm really here to give you some highlights and some things for further thought. And my understanding is that you will get the slides that I use so that you can go over it and work on it your own. All right, so I'm going to share my screen now. There we go. Okay, excuse me. So I'm going to be speaking to you about pressing forward and managing your career so that you can achieve the degree of career advancement that you'd like. So today I'm going to give you an overview of career management. I'm going to talk to you about the importance of your story or how you position yourself. I'm going to say a little bit about making connections or networking, and I'll end with a few frequently asked questions, and I'll give you a few tips. So let's start with an overview of career management. where you start, and I'll say that sometimes people think managing their career starts with seeing a job opportunity and then applying for that job opportunity. It actually doesn't. Where I want you to start in terms of managing your career is when you do that reflection, that blue skying, and thinking about where you'd like to go next and what you'd like to do next. In doing so, you'll set some criteria, whether you're aware of it or not, because you'll have some things that you simply want to have or what you don't want to have. The type of things, rather, where you want to work or where you don't want to work. What kind of people you want to work with and what kind of value you want to create. So what I'm asking you here is, when you start thinking about what's that next step for you and where do you want to be down the road, you start to think about your criteria and actually be mindful about it and write it down. The next thing that you're going to do is assess your current strengths and your skills and ask yourself, do you have the strengths, skills, and experience in order to move toward your goal? And certainly, if you don't, what do you need to do in order to get those skills and develop those strengths? Part of this as well is positioning yourself. So it is so important that you know what you bring to the table, that you know what your strengths are, that you know what you can offer an employer or an organization. And then you need to be able to articulate that. And you articulate what you bring to the table many, many different ways. First of all, what I call your pitch, and that is how you talk about yourself, elevator pitch. As well, if you're on LinkedIn, and I highly encourage that you are, what does your profile on LinkedIn say about you? And then what does your CV or your executive resume say about you? Then you're going to take that positioning and you're going to start talking to people, because you need to do your research. You need to find out what is required from some of the organizations that you're interested in or the field of work. You want to build and continue to build on your professional network. So you need to get out and start talking to people so that you can learn and then they can learn about you. Now, hopefully at that point, opportunities start making themselves known. Either you hear about it or you see it's posted somewhere in your organization or online. In order to put your best foot forward, you can see now that having done all these previous steps gives you a better application, because you know more about the organization or organizations that you're interested in. You know more about the industry or the roles. You know more because you've thought it through, so that when it comes time to make an application, you have a stronger application. Then you get to where you want to go at that next stage, and you get to enjoy. But it doesn't stop there, clearly. You need to continue in your networking. You need to continue in your building of your professional community. You need to continue to maintain your visibility. And all the while, managing and building your professional community. So when it comes to change, you need to position yourself for future change. That future change could be setting yourself up for an internal promotion, building awareness externally, moving to another organization or field, building clientele if you're growing a business, being headhunter ready, or taking on an additional role. What is really important to keep in mind that runways are our friends. What that means is the more time you have to build your professional reputation in a way that is purposeful, in a way that will take you to where you need to go, the better you will do. So from where you are right now, and whenever change might happen, whether it's planned or otherwise, what message and intention will you move forward with? This is part of the positioning. I want you all to know, without a doubt, what you bring to the table, how you add value, and I want you to be able to articulate that. This is part of your brand. So when you're asked that question, tell me about yourself. Or when you're giving thought to, what does my LinkedIn profile say about me? And again, I want to encourage you, if you're not on LinkedIn, I want to encourage you to be on LinkedIn. But that's a whole other workshop. What your resume and your CV is saying about you. How do you answer that question? Tell me about yourself. Do you have an answer? Do you have a professional story that weaves through all of the touch points, how people communicate and interact with you? And think about that as your marketing. Are you aware of your brand and where it will get you to where you want to go? We often think of brands, definitely, we all know brands that are in consumer products and services, but people have brands. So think about your value. You create and reinforce the reputation that will support you moving forward. You will have a brand. You all have a brand, but you have a choice. Do you want that brand by design, meaning you've created it, you're reinforcing it, or do you want one by default, meaning other people are deciding what you're about? I would recommend the brand by design. This makes networking and interviewing and connecting with other people a little easier because you know your message. For example, say you're a surgeon with significant experience in using a particular technique who is passionate about improving the quality of care and patient outcome. That's what you want people to know about you, but that's a message you need to reinforce. Or you may be a radiologist who seeks out and uses cutting-edge modalities in order to deliver more accurate diagnosis in less time. Again, that's what you want people to know about you. And that, having that positioning, which is what you have chosen, you can see how having that makes moving forward easier because you're starting to build that reputation. We all know the saying, it's not what you know, it's who you know. And actually, I want to propose a little different way of looking at that. It is what you know, it is who you know, and it is what they know of you. So, talking about your positioning, I'm going to propose that you follow the following template. I want you, when you are talking about yourself or positioning yourself, to think of 3 key elements. Element number 1, what do you want to be known for? What I want you to do is I want you to have around 3 sentences. What do you want to be known for? And you might start these sentences. I love being able to. I have strengths in. I've been able to create or innovate. I add value by. They can be whatever sentences you want. But this is not starting your positioning by your current title. This is starting with what it is that makes you tick and what you want to work toward. And I'm suggesting each one of these elements has 3 sentences because in the end, then you have 12 sentences, which makes for a very short, concise introduction. So that when people say, tell me about yourself, you've got something ready to go. The second element, this is where you get into telling people what you currently do, establishing your credibility, what your education and training would be, and perhaps offering something that you've done recently that you really want people to know about because it was a really interesting or cool thing to do. Now, why don't you start there? You don't start with, this is my role and this is where I work, because people are listening most acutely to the beginning of whatever you say. And if I tell you I'm a kindergarten teacher and I work at a local elementary school, you start thinking about me as a kindergarten teacher. Now, I may then want to get into a completely different line of business or work, but you still are starting to think about me in my current role. So if you want your role to evolve, don't reinforce in people's mind where you are right now, reinforce what it is that you bring to the table. Finally, the third key element is what you want to do, where you want to go. What are you interested in learning? Who are you interested in speaking to? What would you like to know more about? So think in terms of these 3 key elements. What do you want to be known for? What is your credibility? And what's the direction you want to go? These create for you sound bites. And so you have an answer to questions when people want you to tell them about yourself. For example, for Miriam Salim, she's a physician at Main City Hospital. So that first element, who is she? What is she passionate about? She could say, hi, my name is Miriam. I'm a physician at Main City Hospital. But that doesn't really tell you what it is that drives her. So let's look at some other way of talking about her. I'm a physician, educator, and administrator in women's health who is passionate about providing care for women with complex medical conditions and those who live in marginalized conditions. To do this, I am working to improve equity, access, and representation in healthcare for women with breast cancer. Okay, so now we know something about what makes Miriam tick. What's her credibility? I'm a medical doctor who trained at the University of Jordan. I also have training in breast surgery and oncoplastic surgery. I'm part of a team developing multidisciplinary breast care clinic that is a one-stop shop for patients, reducing the fragmentation of care. Wow, we're sure learning a whole lot more about Miriam and what makes her passionate about her work. And then finally, what is she talking to people for? Where does she want to go with all of this? Well, I'm talking to colleagues and others in our field to learn about how they create effective practices that can improve patient outcomes. I'm eager to learn about global best practices and partner with people around the world. So hopefully you see that that is so much more interesting than simply saying, this is my title and this is where I work. So now that you have that statement about yourself, let's take it on the road. So when we talk about networking, what we're really talking about is simply having a conversation with someone. It is at its core the exchange of information and ideas amongst people with a common profession or a special interest. What is it really about to network? It's about learning and sharing. What would you like to know? What would they like to know? It's about having a genuine curiosity with the focus on them, their career, their experiences. So when you say to someone, gee, I'd love to have a cup of coffee with you. I'd love to, perhaps let's have lunch. I'd like to hear more about your background. Focus on them. Become an investigative reporter and find out about what brought them to where they are now. A great first impression is about establishing an authentic, deeper connection. Perhaps this is an opportunity as well to get useful advice, perspectives, and new ideas. So you can see that when you've been blue skying and thinking about possible career opportunities, you need to find out more. Is this really what you think it is? Is this really where you want to go? Are you a good fit for it? And is it a good fit for you? The only way you are going to find out is by talking to people in that field or in that organization or in that role. And for long term, it helps with your career development, opportunities, and growth. Networking is a career management tool. People often think about it's only something that you do when you're looking for a new opportunity. Think about the runway. You need to build that runway, those connections, that professional community, because you will need it at all points throughout your career, not just when you're looking for a job. So for ongoing career management, networking allows you to have a better perspective on your organization, industry, or field, and give you an awareness of new developments and trends. When you're ready to make a career change or a job search, it gives you that knowledge about trends and challenges, positioning yourself as relevant to the employer. Remember, employers hire people to solve problems, so you need to know what problems an organization has. So what does that organization need in terms of skills and ability? You need to get on their radar screen, and you can see by doing this, you are going to be so much better prepared for a job application and an interview. So who do you network with? Well, in short, just about everyone. Current and former colleagues, fellow alumni. Don't overlook your family, your friends, or your neighbors. Everybody is connected to someone else. And on that note, second and third degree connections. So who do people that you know, and who do they know? Certainly when you're with an organization or associated, there's events, professional associations, and then of course on social media. So here's some common questions. How important is it to have an introduction or a positioning statement? Well, clearly, I'm going to tell you it's very important. You need to have something in mind that you will say about yourself when asked, so you're not caught off guard. I want you all to know what you bring to the table, right? You need to know. You cannot sell yourself to an organization if you cannot articulate what it is that you can do for them and how you will bring value. Think about what you want people to know about you. Okay, here's a question. I'm not comfortable bragging about myself, nor is it culturally acceptable. So how do I position myself? Well, first of all, please don't brag. Being confident and self-assured and aware of your own strengths and abilities is not bragging. It's simply saying, this is what I love to do. I have a real knack for it. It brings me joy, and I'm able to create value. Your focus is to know what you're passionate about, what is important to you, and how you create value. So when you're connecting with others, how can you make the biggest impact? Well, prepare. Prepare, prepare, prepare. Who are you talking to? Who are you planning to meet? What is it about their background that interests you? Show others that you're interested in them. Know your own message and then focus on them. You can make more friends in 2 months by becoming interested in other people than you can in 2 years by trying to get other people interested in you. Okay, another question. Who is appropriate to reach out to and who isn't? In other words, who can I ask to have a cup of coffee? Well, almost everyone. If your request to connect with someone is polite and professional, no harm is going to be done. If the other person declines, and some people will, that's okay, just move on. If you're interested in a role, aim to speak to someone in a similar role or that same role, but don't overlook more senior people where possible. Many are very keen to help. As a professional woman, how do I improve my profile in a male-dominated field? Okay, know your message, know your strengths, connect with like-minded people, build and nurture your profile, and network with men and other women. Don't wait to be discovered. All right, you could be doing amazing, amazing things, but if you're hiding your light, no one's going to know about it. So you really need to know your message and know your strengths and be able to communicate it. Start with having a cup of coffee or tea with a coworker with the idea of getting to know their professional history and interests. People love to talk about themselves. How do you ask for a chat? So now that I'm encouraging you to network or network more, how do you ask for it? Short, clear ask. Okay, that's either in a note, being an email or a voicemail, or you just walk up to someone and say, hey, I'd love to chat, or a LinkedIn message. So the first thing you want to do is establish a connection. Hi, Katie. I met you at an event 2 weeks ago, and you were talking to me about the work that you're doing in radiology. I'm a radiologist, and I'd love to talk to you a little bit more about that. What was the connection? Did you go to a similar school, the same school? Have you worked in the same organization? Is there something about their career to date or something that they're doing now that you have in common? Find a commonality and let them know that. Then be very clear on what you want to meet with them and why. So why do you want to meet with this person? Make sure that they know it's them that you want to speak to. And then importantly, clear next steps and a call to action. It's not enough just to say, Katie, I'd love to talk to you sometime. And then I'm left with, well, how's that going to happen? The clear next steps or call to action could be, I'd love to talk with you sometime. Would you happen to have a half hour over the next couple of weeks where we could sit down and have a cup of tea? So provide an idea of the timeline and what it's going to look like. How do you maintain your network? Easy. Reach out and share an article, a link, a notice of an event when it might be of interest to your connections. Use widely followed holidays or occasions to say hello and send greeting. In almost every country, in almost every culture, there's holidays or occasions when you can simply reach out to someone and say, hello, I hope you're doing well, my best to you and your family. Follow people on LinkedIn or Twitter and comment, congratulate, thank, etc. And when there's any kind of change in your career, you've gone to school, you've got a new certification, you've been part of a very interesting project, share that. But don't worry about how am I going to do this once a week? No, 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 no. Every couple of months, couple of times a year, that's okay. That's enough. So here are a few tips. I want to close with a few tips. In terms of positioning yourself, make sure that you have a way of simply conveying to others what you want them to know about you. Thinking about your runway, what do you need people to know about you as you go along? The purpose of your way of talking about yourself is to connect with the other person and help them see what you are interested in and what you're about. Importantly, let your positioning evolve as your interests and targets evolve. All right, do not write this in pen, write it in pencil so that you can update words and phrases. You can update it as you learn about things and as your own interests change. Importantly, I want you to make sure that whatever you land on, it is comfortable for you and it feels right. If it isn't comfortable for you and it doesn't feel right, you are not going to use it. And then that defeats the whole purpose. Make sure that all of your messaging, your resume, your CV, your LinkedIn profile, if you're on Twitter, whatever you're saying on Twitter, all your communications reflect that core message. Again, think about a consumer products good and how the message is repeated over and over and over again. Okay, tips on connecting and networking. Leverage the power of existing connections. Focus on building long-term relationships, not short-term transactions. Never, ever, ever, ever connect with somebody to say, do you know if you're hiring? Do you know if your organization has any opportunities? Do you have a job for me? That's transactional and nobody wants to be part of a transaction. So focus on building long-term relationships. Focus on the person that you're meeting with. Learn about them. You can say, I'm interested in your career path. Will you tell me please tell me more about what skills and abilities are most highly valued. I'd like to learn more. Can you suggest any resources I should explore? Or importantly, people I should connect with. Ask to stay in touch and connect on LinkedIn, follow up and follow through, and keep track of who you speak with. That's it for me today. Thank you for your time and enjoy.
Thank you so much, Katie. A lot of things resonate and fantastic advice as always. I love the part about don't wait to be discovered. That's awesome. Thank you so much, and more to come in the reflections and the questions and answers. Thank you again.
My pleasure.
It's a pleasure to start the Barriers and Opportunities for Women's Leadership in Healthcare session. The objectives of this session are the following: to reflect on the importance of equity, diversity, and inclusion for women's leadership in healthcare, also to highlight challenges such as unconscious bias, while shedding light on important barriers and opportunities through shared global experiences from East to West. It's a pleasure to be joined by wonderful women leaders in healthcare. Dr. Lenu Stoddart is a colleague of mine that we've worked together in Massachusetts many years ago, where we both sat together at the multidisciplinary care taking care of breast cancer patients. Lenu will be talking about her journey with barriers and opportunities for women in healthcare, giving some tips to those budding leaders in healthcare. So Lenu, welcome. She is the National Medical Director for HemaCare in the US. Lenu, go ahead.
Thank you, Rola. It's a pleasure to be here with you. I'm honored to be asked to join you today. Addressing barriers to leadership or to getting where I am today, I think for each woman, it's going to be slightly different. I would say in my circumstance, clearly I'm an African-American woman. For me, I grew up in a typical middle-class town in Massachusetts. It was predominantly Caucasian. There were not a lot of role models for me as an African-American woman as physicians. There were none in my area, none in my community. So I looked outside of that, people in my parents' life, friends of my parents, There were no female physicians, but there were dentists and physicians, and I had aunts that were in nursing. So I would say the biggest thing for me was to find that role model. And I did that by reading, by watching TV, by listening to documentaries, and learning about other Black women out there who are in leadership positions and who are physicians. Another barrier I would say was still in my day, ironically enough, was females getting into school, and African Americans having the opportunity to get into medical school. But I was lucky enough to have the opportunity to go to University of Massachusetts Medical Center, to University of Massachusetts Medical School. And that school actually broke a lot of barriers, very non-traditional. As a matter of fact, 50% of my class was female, and it was an exciting place to be. There weren't a lot of African Americans. I think there were 4 of us at the time in my class. But the opportunities and the barriers were there, but we had a lot of support from our student affairs office. And then once I was in that environment in the medical school, there were other African American physicians and mentors that I gained. In the working world, we still see the same barriers, even though it's in the 21st century now. I was in school in the 20th century, but still we saw some barriers. But I was very fortunate. My goal was to always just be myself. And if people wanted to accept me the way I was, then that was fine. So I was fortunate enough to get into a wonderful residency program, both in transitional year at Kettering in Ohio, and then in pathology, both anatomic and clinical in the Boston area in the Harvard Medical School system at Beth Israel. And then I had that same attitude when I went out interviewing for fellowships. I got into Yale, and then the same attitude again when I went out for job interviews. And I took a position in New Mexico, of all places, in Albuquerque, and that was a wonderful opportunity. So, talking about barriers, there are a couple of events or experiences that I had that really pointed to how we as women need to stand up for ourselves. And one of them happened when I was doing my internship. I was doing a transitional medicine year, and we had a visiting professor who gave rounds one day. And unfortunately, it was an infectious disease talk. It was an excellent talk. But between each topic, he had an image of a beautiful, luxurious car, and then a scantily clad woman on or near the car. And this happened repeatedly throughout the presentation. And I was just furious. I had just left UMass Medical School, and we were really empowered as women there and as women leaders to stand up for what was right, to honor one another, to respect ourselves, our bodies. And then here I happened upon this terrible lecture. So I spoke to our department head, our program director, right after the lecture, and he says, I think you should approach the speaker. And I did. And I think back on it now, like, how did I have enough guts to do that? But I did. And I just said, what you had to say about infectious disease was phenomenal. However, I was terribly insulted by how you treated women in your presentation. And he appreciated my feedback, and he said, he hadn't thought of it that way. And I think at that time, we're in such a society that you take things for granted. As men and women, oh, it's a pretty car. Notice that shape, those curves look like the curves on the model. And that's just not appropriate. I was grateful that he took my criticism so well. He did say that he would be removing those things from his presentation in the future. One of the other barriers that I faced, and it took some transition to break my way in, was a community hospital in Massachusetts. My partner was a wonderful gentleman who was several years my senior. It was like working with my father or my grandfather. We had an excellent relationship. And when I got there, he says, "Oh, I'm so glad you're here. You're going to become the new department chief," which I did become. But he said, "I want you to take a role and take over my place in medical staff leadership. And I'm going to nominate you for X position." And when that nomination came up, literally, it was all male officers, even though there were female physicians there. They said, "Oh, that we're all set with that position. It's already filled." And it took several years to break through. It was very much an old boys network when I came into that facility. And that was in the mid 2000s, rather shocking for a progressive state in Massachusetts, in the United States. But I watched in my time there that probably I was there about 10 years. And it took that time for those barriers to get broken down and more women to take a role in leadership. As for opportunities, we can seek our own opportunities. I think in the West, or at least in the United States, things have really opened up and the sky is the limit, at least in medicine. And I think providing you have the education, you've got your residency program, you can use that training period to start networking. Start networking with your own colleagues. Like, for instance, if all of your attendings are male or majority are male, start networking with colleagues outside of the department. Look for females or men who want to see women develop. You can network amongst your own residency colleagues, so that maybe when you leave residency, you can start a group together, or at least you'll have people that you can discuss things with as your career develops. And that was helpful for me. I am very close to one of my attendings from my internship days, and from residency colleagues from my internship and from my pathology residency. We remain very close. And that has helped because when I need professional advice or personal advice, I have someone to go to. And in the professional environment, I think you have to be careful of not being afraid to ask for things. Be observant. One of the things that I noticed when I first started working, I joined a group out in the Southwest, is there was an effort to limit salaries, I thought, for women who were not partners in the group. One of the questions that I was asked was, well, is your husband working? And I thought that was an odd question. It doesn't matter if my husband is working or not. I need to be paid what is due to me as a professional. So be careful of those things, but don't be afraid to ask for what you know you're worthy of. One of the other things that I would say is don't be afraid to take risks. So for instance, if somebody offers you an opportunity, instead of saying, "Oh, that's going to be so much work," think about what this will do for you and how it will fulfill the dreams that you've had over your life. Don't be scared of it. Yeah, it can be frightening, but don't be scared to take it on, because once you start taking it on, you'll realize that you do have the skills to do it and you can develop that opportunity into something great. The other thing I would say is when you're, like say you start a new position and you notice a gap, you'll say, well, nobody is doing XYZ, but I think that's very important. start calling attention to that area, but not to say we need somebody to fulfill that, but you fulfill it. You take on that responsibility, make it work, take on that project that nobody else wants to touch and make it work. And then people will start to see you, not for your external, whether you're African American or female, but for the strong, smart individual that you are and what you can bring to the table. And I found this to be true over and over and over again. And don't be afraid to support one another. Women have a tendency, at least in the West, to once they get up there, they want to stay up in that leadership realm and not help people up. You have to be willing to help people up and support them. It's very important. Always be kind. That would be one thing that I would say. You can be assertive, you can be firm, but always, always be kind.
Thank you so much, Lenu. This is a great message and a lot to reflect on. Thank you so much for sharing your wonderful experiences, and we look forward to the questions and answers session. It's a pleasure to introduce Dr. Abir Al-Mulla, a radiologist from Saudi Arabia, one of my wonderful friends who we have met back in Massachusetts many years ago and have done workshops and conferences together in Saudi and in Abu Dhabi. She's very keen on advancing women's imaging, even though that she's a body imager. She has a wonderful journey in her career with leadership positions, and it's a pleasure for Abir. It's a pleasure for us to be with Abir today and talk about barriers and opportunities for women in healthcare, and with some tips for those budding leaders in healthcare. Thank you. Go ahead, Abir.
Thank you very, very much, my dearest friend Rola, for this beautiful introduction. And I think this subject you are tackling is quite a burning subject. I think all of us, we need to hear each other in this regards, especially from different cultural domains. So if we start with the barriers regarding the women in leadership, I think there are things that could be in common between us in this part of the world and the Western culture, maybe. I don't know if they are in common or we have different degrees of all, but I'm sure there are variabilities in every place. So maybe we learn from each other about maybe to which extent these barriers are existing and what are the best ways to tackle them, even though we are having different perspectives or cultures. Regarding our barriers, I would say I would start with the cultural barriers. Unfortunately, there are in general deep-seated cultural barriers, which is basically related in this particular part of the world, particularly in the past. Nowadays, it's changing and it's swiftly changing. It's the discomfort in dealing with women leaders, particularly with the past culture of segregation between men and women in the social perspectives. So it's kind of subliminal thing that is discomfort rather than a spoken part of the issue. Also, there are kind of subliminal skeptics, both in men and women, about the inconsistency of the availability of women leaders in their roles, particularly in childbearing age on the budding woman. So everybody is skeptical that within the critical time, this woman is going to be available in her role the way and the right way we needed her. Now, there are other limitations or challenges or barriers that are related also to the culture in terms of limited informal inclusion and networking. Maybe this is existing even in the West, because sometimes men, they have their common activities that are informal, but it's serving a lot in terms of engagement and interactions related to the profession or the domains they are working with. So this limited networking is kind of a barrier that we face as women. Now, there is something that we encountered, which is related to what's called role incongruity. The expectation that the masculine and the women, the feminine traits are affecting the roles of leaders. So when it comes to assertiveness, the independence, the competitiveness, we rely to the masculine traits in that regard. When it comes to the delicacy and the expressivity and the passion, is misperceived as emotional response, and this is sort of as feminine, kind of trait. So those are barriers as well, despite they are not very visible, but they are playing major role. Actually, the women leaders are in real challenge. They are, in this hair thin line between two opposing sets of expectations that they deal with things as leaders and they deal with things as women. But I think with mentorship, with the right guidance, with the right acknowledgement, they can do even better with those challenges by acknowledging those challenges and the expectations, whether being feminine or masculine in the usual terms, and dealing with them in a better way and in their own distinction and uniqueness. I think these are, the higher level barriers, because if we go to the scenarios, I think they will be endless.
Thank you so much, Abir. How about some opportunities that you can highlight?
Good question again, Rola. I think sometimes the women are their own enemies when they are subjected to their own emotional suppressive factors, one of which is attributing everything to being a woman. Despite the challenges that we need to acknowledge, we need not to attribute things to being of this gender. And this is the biggest opportunity. If I forget that I am being challenged as a woman, I will do much better. This is number one opportunity. I think in my own experience, this did play a very good success factor in the progression of my leadership role. So we need to avoid thinking that way. The second way, maybe in this part of the world, things are not very systemized and standardized, and sometimes chaos is an opportunity. So with having the right knowledge, the right talent, the right fit, I think we can do miracles. So we can always think in how to convert the challenges to opportunities and deal with challenges, overcoming them by the right knowledge, the right, creativity. Even sometimes you need to use both your left and right parts of the brain in scientific and artistic ways. And I think these are major opportunities in doing great in leadership. And I think the woman with her own spectrum of capacities, if you may, with her own delicacy and meticulousness, with her own multitasking, default, I think these are major opportunities that you can conceptually subject them on every scenario and tactically create your own path.
That's great. Thank you so much, Abir. If you're going to say one last thing for those budding leaders, women leaders in healthcare, I know you highlighted very important opportunities. Do you have any last words for them?
Okay, I think in that scenarios, first of all, I would like to give my own perspective in this regard when it comes to men and women. I would like not to deal with each other as competitors. So maybe if we are integrative, we're gonna make this world a better place. And by that, having the right fit and the right capacity, I think we both are going to be living in peace, and the outcome is going to be great.
Thank you, Abir, for your input. This is awesome, and we have a lot to reflect on.
Thank you very much, Rola, for this opportunity, and all the best.
It's a pleasure to introduce Dr. Elsie Nguyen, who is an associate professor of radiology at University of Toronto. She will talk about barriers and opportunities with tips for women in leadership in healthcare. She will also tackle the support for inclusion, diversity, and equity.
Hello, it's a pleasure to be here and thank you for the introduction. I have no disclosures. Today, I hope to identify 3 common barriers to women entering healthcare leadership positions. I will describe some strategies to mitigate these barriers and also identify areas of opportunity to encourage women to become healthcare leaders. I am the Equity, Diversity, Inclusion Vice Chair at the University of Toronto Medical Imaging, and I want to first touch upon some myths that often circulate in the EDI world. First of all, there's a lot of talk about increasing diversity in our workforce, and there's a common misconception that a diversity hire means a sacrifice for quality, and that's simply not true. Focusing on diversity doesn't mean that you have to hire someone who's unqualified or not as qualified for the job. It just means we need to do the work to encourage underrepresented groups to even consider applying for trainee or faculty positions, and especially leadership positions. Another misconception is that work in EDI involves erosion or goes against a meritocracy, and that's not true either. EDI work, of course, doesn't replace hiring the right people for the right job. And of course, we care about the merits of each applicant, whether it be a resident applying for a radiology residency position or faculty hiring for a post or applying for a post or leadership position. And lastly, there is a group of people in academia who believe EDI work doesn't belong here. And this was published in the Globe and Mail, for example, and they see it as reverse discrimination. Of course, this is not what EDI is about, and discrimination of any kind is wrong. So I just want to say that this is not what we're trying to do here. We're trying to raise awareness, and we're trying to look at areas in our system that are unjust or unfair and create unnecessary obstacles for underrepresented groups, in this case, women, from entering healthcare leadership. So before I move on, I just want to be clear that our audience understands the difference between equality and equity. Equality is just treating everybody the same, giving everybody the same thing regardless of need. And in this cartoon example, you can see the wooden fence is preventing a view of the soccer game, especially for the shortest person. And if you give them all the same supports, i.e. the same box to stand on, it still doesn't help the person who needs a little extra support, let's say. Whereas equity is looking at who needs a little extra support and giving those supports to those people. So in this case, the shortest person is given a larger box to stand on, and this allows the shortest person to view the soccer game. But where we'd like to move towards is this concept of justice for all. And that's what I'm trying to work towards, really looking at systemic bias and systemic discrimination. And what is it about our infrastructure that provides barriers to people and barriers to them succeeding? And could we dismantle those barriers? And in this example, the wooden fence is replaced with a chain link fence, which of course now allows everybody, irrespective of height, to view the soccer game. So today's talk is focused on women in healthcare leadership and what are the barriers and opportunities. It's certainly true that there is a systemic bias and a lot of stereotypes that prevent women from entering healthcare leadership. Sometimes women who possess the same characteristics as men might not be viewed as good leaders. Agentic traits relating to a sense of agency. So agency is the concept that a man or woman or non-binary person could have control over their outcome and destiny through their actions. And you can see listed below are some adjectives that are commonly attributed to male leaders on the left compared to female leaders on the right.
Women leaders tend to be expected to care about the group. How do people feel? And to be more sympathetic and understanding and more sensitive and caring. So some of these stereotypes can serve as barriers to women ascending to leadership positions because they're not seen as potential good leaders. Another significant barrier to women in healthcare leadership is the fact that we don't have a lot of role models who are women. Certainly male role models can help women develop their leadership skills. It doesn't have to be a woman, but there certainly is a lack of women in healthcare leadership. And this is true in the US, for example. Most of the CEO, chief financial officer, as well as chief medical officer positions in different health systems, as well as health insurance groups, most of these positions are held by men. The only area where women are pretty well represented is at the division leader level in the Department of Health and Human Services in the US. And so how do women compare? Well, this recent paper showed that if you look at academic rank across Canada among radiology faculty, the number of associate and professor academic rank goes down in terms of the proportion of those professor designations held by women. Much fewer female full professors compared to male. But interesting fact is that on average, female full professors had more publications and higher H index rankings. And then when you look at first in command leadership positions, again, by far, these positions are held by men, and only about 30% of these first in command positions are held by women. So this other study published recently showed that across Canada, among radiology faculty, only 31% are women, very similar for residents in the last 2 years, about 32 or 33%. And what's interesting is they noted that the more women you had as faculty, this seemed to correlate with the number of female radiology residents. And so the programs that had fewer female residents also tended to have fewer female faculty. And this is just the same data represented in a graph showing that there is a correlation. If you want to increase female faculty, you need to start with the residents, but you need to have more female faculty to begin with. That seems to correlate with the number of female residents. And what this is telling us is that representation matters. You cannot be what you cannot see. And I learned that from my colleague, Dr. Carolyn de Benedictis. You know, we really need to show our trainees what the landscape could look like, and we need to be visible and supportive for them. Another thing I wanted to speak about is the fact that women, as compared to their male counterparts, tend to be fearful of failure and fearful of making themselves vulnerable, fear of taking risks. And I have to say this is definitely true. Like, a woman will wait until she's overqualified to apply for a job. And in contrast, a man probably would apply for a job even when he's not qualified or inadequately trained for the position. Another big barrier for women is the fact that we have two jobs. You know, we joke about this, but it's true, and I live it. You know, after finishing a day at work, we go home to our second full-time job, and that's to take care of kids, if you have any, or manage the house. These certainly are barriers because they are other areas of focus, and family commitment is huge and it takes up our time. So these are certainly reasons why women do not enter into healthcare leadership. One thing that I have found incredibly helpful to change things is unconscious bias training. And this is critical for every member of a selection committee, whether it's for radiology residency interviews or for faculty hiring or promotion selection committees. You really need to be aware of your unconscious bias and to address them. And I've undergone this training, and it's really opened my eyes. And it just, you know, encourages us to be more fair in how we assess candidates and to move away from conventional metrics of success like test scores and things like that in the context of radiology residency interviews. And the slide here is just showing how you can address the fact that there is unconscious bias and what you can do about it at both the organization, individual level, or both. And one thing I do want to highlight is it really does need to have some buy-in from leadership. If the academic chair or radiologist in chief at a hospital is not supportive of EDI work, it really doesn't make it possible to accomplish anything meaningful. And another term you may have heard of is the concept of a leaky pipeline. And basically that refers to the attrition or the loss of people from the beginning to the end. If we think of this pipeline as starting with a medical student, for example, and leading to the full professor in academic leadership, there is a leakage or an attrition. We lose people. But what can prevent that attrition is mentorship and sponsorship. In my practice, I have seen junior faculty struggle, and some have left the academic practice setting to go into the community or maybe do clinic work because they haven't really found a pathway to success. And so in order to keep people in academic radiology, for example, we really need to support them, pair them up with mentors or help them succeed by giving faculty a way to support these more junior entry-level radiologists, giving them the support they need. So what is the difference between mentorship and sponsorship, by the way? Mentorship is basically a guide for your professional life or outside of work life, but a sponsor is usually somebody in an academic or organizational leadership position who can open doors for you and create opportunities. The same person can be both a mentor and a sponsor, but they don't have to be. And the other thing we might have to consider is maybe we need to connect our water source that's leaking water and leading to this attrition to a larger upstream water source. And maybe we need to speak to high school students and get them interested into radiology and address underrepresented groups and not just medical students in order to make sure that at the end of this pipeline, we still have women and other underrepresented groups in healthcare leadership positions. Faculty development is incredibly important, and I just wanted to highlight the excellent work done by my colleague, Dr. Lucy Spaluto, who has really taken the issue of underrepresentation of women in radiology head on. And she's been able to increase the number of faculty and radiology residents who are women well above the US national averages, which range from 25 to 29%. And she's done this through targeting career development workshops, a formal mentorship program, and a lectureship which invites different faculty across the US to come and speak at the Vanderbilt University on topics relating to women in radiology. And she's also done work to target high school students in the area to get them interested in radiology. And she's been successful at increasing the number of underrepresented minorities, URM, in radiology. And you can see here across the years of residency that they're well above the national average for underrepresented groups. At the University of Toronto, we've done our own outreach to medical students this past year, focusing on DEI in radiology, and it was an incredibly successful event with a lot of uptake in interest among medical students in radiology. So Dr. Spaluto also says, okay, you need to do these things to address the fact that women are underrepresented in radiology. If we think about 50% of medical students are women, only about a third of faculty and residents in radiology are women. So we're definitely below average. We need to understand the needs of these underrepresented groups. We need to support them with clear, transparent promotional guidelines to help them succeed. And I think this should be part of the welcome package when new faculty are hired. And we need to create opportunities for career development, and through sponsorship we can do this, open doors for faculty and residents from underrepresented groups, and also to increase their networking experiences and opportunities. So Dr. Spaluto has specifically addressed workshops on the following: promotional guidelines, work-life balance, how to build your educational or research portfolio, how to improve your CV, how to write and review for medical journals, as well as how to get into educational or hospital administration leadership positions. And workplace flexibility. This is a tough one. I can't speak a lot to it because we don't have, quite frankly, a lot of workplace flexibility. But what is meant by this? It's basically part-time work. Can you work part-time? Can you work from home? Maybe more desirable or fair policies on maternity or parental leave, having that paid or a larger portion of it paid than currently, and maybe having an on-site daycare. These measures would certainly allow faculty and trainees with families to feel welcome and to have an opportunity to succeed. So it's really incredibly cold in Toronto right now. I'm sure in Dubai it's much better weather. I hope you will visit us sometime in the future. And I hope in the future we at the University of Toronto will have greater accomplishments to share with you in the EDI world. Thank you so much.
Now we're going to a great session where we're going to learn about breast surgeon journey, starting with Dr. Dalal Aziz, who is a breast surgeon working at Milton Hospital in Ontario. Dalal, go ahead.
Good evening, and thank you for the opportunity to present. I was asked to present my journey in general surgery by Rola in 10 minutes. I will start by pointing out that I am far from the finish line, if there is ever a finish line. Sorry, double advancing. It all started when I decided to apply for the general surgery residency at the American University of Beirut. This is a picture of my village high up in the mountains. In the 1990s, there were no female general surgeons who have graduated from my university or who have practiced in Lebanon. I ranked general surgery as first on my application and internal medicine as second. After the interviews, the internal medicine chief asked me, "So what rotation do you want to start with?" And I replied with surprise, "Why, am I not accepted into surgery?" And he looked at me so perplexed, as if not understanding what has possessed me. I started my residency in general surgery. I was given a disproportionate number of the difficult rotations, like cardiac surgery, where you do all the legwork and learn little. But I worked hard and I did not complain. I thought I was being a hero. But I was wrong. I should have advocated for myself to get fair rotations. I felt so lucky when the staff would let me do a case or genuinely try to teach me. I did not know that it was my right and not a privilege. And when I got married during my residency, my staff told me, "Dalal, don't get pregnant." Well, he was right. With no maternity leave at our program, pregnancy would have meant the end of my surgery dream. But in retrospect, I have good memories from my residency years. I had lots of support from my staff. I had spent great time with my colleagues, and I built long-lasting friendships. I was so proud when I became chief resident and I graduated from the American University of Beirut as the first female general surgeon. And this broke the stigma that females will not finish the surgery residency. And I hope paved the way for future female applicants. After that, I moved to Canada to pursue my training. And it was a totally different world in Toronto. Female surgeons, many of whom were my mentors and supervisors, were professors, were doing research, had leadership roles, and received referrals from all over the province for the most challenging cases. And this was very inspiring to me. After I finished my training, I got a job at a community hospital. I was so excited. It was a charming place, great to raise a family as I had 2 children. I thought I'll have no problem building a successful practice and thriving, bringing extra skills to the table. Well, I was wrong. I had to work harder to gain the trust of the community, the family doctors, and my colleagues. What I did not expect at all was the attitude of the OR staff. The female surgeons were given the royal treatment, while I was expected to accommodate their schedule. Again, I was the first female general surgeon in that hospital. And things only improved when a new female obstetrician became the chief of staff. She came from a bigger center and helped change the culture of our hospital. And by that, I mean not only male surgeons' attitudes and behaviors, but also female nurses and managers who had a hard time treating female surgeons the same way they treated their male counterparts. I really want to emphasize this part because I strongly believe that females will advance and prosper in their careers only if they commit to helping each other. And despite whom we choose to blame, we hold the key to the change we desperately seek. Over the years, our hospital more than tripled in size and the community we serve grew much bigger. Being mindful that I was working in a community hospital, I made sure to keep up with the literature and the latest surgical advances. I kept up with my laparoscopic skills. I incorporated the oncoplastic techniques in my practice. We started a diagnostic assessment program and oncology programs to treat our patients locally so they don't have to travel far. We recruited a breast plastic surgeon. And our hospital evolved to have a well-rounded breast program. We were the first in Canada to acquire the ultrasonic breast localization for breast cancer, and we are constantly thriving to improve and help our community. An opportunity came up for a leadership role at our corporation that consisted of 3 hospitals, and I applied. And that raised a lot of eyebrows as I was not part of the traditional club, so to speak. But I got elected as vice president of the Professional Staff Association, and after a few years, I became the president. And this opened my eyes to the administrative work that supports our clinical operations. I quickly realized a very disturbing pattern. Female physicians constituted 45% of the physician working force, and yet less than 1% of physician leaders were female. Actually, the Medical Advisory Committee was nicknamed Old Boys Club. And when you ask why, the usual answer is, females are busy with their families and do not apply for leadership roles. I did voice my concern and the hospital listened, as I can be very loud. So we developed a medical development leader. We created a medical development leadership group to analyze the current situation, to find the barriers for female physicians to pursue leadership roles, and to present some solutions. And I will share with you some of our findings, as I believe that they are not unique to our institution. About 50% of physicians who did not consider applying for leadership describe lack of skills and training. Our medical training prepares us to treat our patients, but it does not prepare us to lead, which require a totally different set of expertise. Now, those who have considered applying worry about the fairness of the recruitment process. In other words, they believe that the chief is already pre-chosen, so why bother apply? And less than 1% cited family reasons as significant barriers to apply for leadership roles. Also, a common theme was lack of succession planning. We presented our findings to the board of directors, and I'm sure you are all asking what has changed. We have introduced leadership courses with focus on coaching and mentorship. We struck a diversity and inclusion committee. There is more awareness of the need to change the medical advisory membership to be more gender representative of the working force. But change will take time to happen, as you need to change people perception and biases. And by this, I mean both males and females. Females hold key positions on selection committee, human resource teams, strategic planning and development teams. And change does not happen by accident. So let's use the power we have to make use of the full potential of prospective female leaders. If you want to sit at the leadership table, we as females need to support each other and invest in the younger generation. In summary, my journey has not always been easy, but I continue to evolve, adapt, and embrace change before it comes knocking. And I'll end by this quote: you can waste your lives drawing lines or you can live your life crossing them.
Thank you so much, Dalal. This is awesome overview. And see, you could do it in 10 minutes. That was great overview. And thanks for sharing this valuable information. I'm sure it's inspiring to a lot of leaders. Thank you. It's a pleasure to introduce Dr. Angel Arnaout, who is a breast surgeon and professor of surgery at the University of Ottawa, who's also going to share with us her journey. Here you go. Thank you.
Hello, everyone. I'm pleased and honored to be able to share with you some reflections of my journey as a surgical oncologist in Canada. Dr. Shaheen asked me to talk about some tips I learned along the way and some reflections. And so it's been 15 years in my journey as a surgical oncologist and clinical research chair at the University in Ottawa, Canada. And I'd like to start by showing you the timeline of my career. You could see that here it looks like it's as if I systematically planned the upgrade of my university status from assistant to associate to full professor, and also my leadership roles from regional to national director in surgical oncology. And along the way, got some training, not just in medicine, but also in business administration. And so it looks like this has all been planned, but anybody that's gone through a long career timeline understands that it's not actually a linear path. There are a lot of ups and downs along the way where you might deviate from the linear path and question and prioritize and reflect whether you're going in the right way. And not everything is smooth. I certainly did not experience a smooth journey. There were a lot of times where you just had to keep the focus going, and I'll talk a little bit more about that. But the deviations from the ultimate career goal don't happen in the beginning. They happen about 5-10 years in, when you have to make choices about what you want to leave in terms of your legacy and your impact for your career, what you want to be remembered as after you retire. And it seemed in the beginning, I remember it was easy when you went into medicine and I went into surgery, thinking that that was it, that was going to be my destiny and my life plan, and that I would be happy seeing patients and operating on them and nothing else. And that's still true to some extent, but as you get further along your career, you want more, and that's where you take on some leadership roles. So I'm still growing, and that's why I said in the beginning, my journey is not finished yet. And so it's kind of ironic that I'm asked to talk about how I did it, because I don't feel like I'm done. So a couple of reflections I want to start with that I've learned along the way. First is that, as I mentioned, it's not a smooth path. And ultimately, I think if you're going in an upward trend, then I think that's what matters. And the idea is just to keep going. If you are good at self-reflection, I would suggest everybody, every 5 to 7 years or so, sit down and map out the next 5 to 7 years. And we're taught to do that, but not many people actually do it intentionally and remind themselves of what they had planned every single day going forward. And the idea of making sure that you are moving in the direction that you ultimately desire is important, so that you don't end up losing focus and losing track. And so it's not that you will not have hiccups along the way, you will, but as long as the ultimate general trend when you look back is towards the goal, then I think you've succeeded. The second thing is focus. And I can't stress that enough. When we first start, we have broad interests and we want to be good at everything. And to be honest, about 5-10 years into your career, you should really start to think about what makes you unique and what can you do that nobody else can do. And that's what's going to make you stand out. And And I was told early on in my career, find something that's both high impact and controversial, and really study the heck out of it, write about it, and concentrate on it, do editorials on it, think creatively about it, go at it from all different angles, whatever topic you're focused on, however small it is, to try and be the world expert on that specific topic. And, you know, if you just talk about it, that's good. But if you write about it, then people can refer to you. So try as much as possible to write as many different versions and editorials and aspects and perspectives on the topic that you think you should focus on, and try and narrow down your broad interests. It's so easy for all of us to, you know, try and learn all kinds of new things. But if we want to be remembered for a certain thing, it's really needing to focus. And the final third thing I wanted to share with you in the 10 minutes that I have is this idea of balance. And, you know, we're taught about, you know, having a work-life balance. That means making sure you have boundaries. Traditionally, the people are telling you have boundaries, that you go home and then you stop the work. And then when you go with your family or you go outside with friends, you know, that's how you rejuvenate and energize so that you can come back and do more work in a more efficient and satisfying way. And that's nice. And I really envy people that know how to do that. I've never really found a good way to do that. My balance is the idea of having everything going at once. And I don't see boundaries. Work is my personal life. My personal life is my work. And you become like that if you work in an area that you're passionate about. I think hopefully many of us are lucky to find our passion that is also our job and our work and our career. And hopefully many of us find that our career is actually our calling, and that we have a purpose in life, and the purpose is to do something for others. And the balance therefore becomes lost in the traditional way, because the whole thing blends together. What makes you happy is your personal as well as your professional life. And so I found this Albert Einstein picture of what he defines balance. And I really think highly of that. And it's really like riding a bicycle. And so if you stop, then you lose balance. If you try and walk or not focus on riding, then you'll lose balance. And so the idea is to keep both and everything going in your specific way, and that whatever way keeps you happy is the balance in your life. And if you have a mix of children, family, friends, outdoor life, you know, hobbies, sports, whatever that you can mix in between your work, and your work helps you want to do those personal things, your personal things help you do the work, then that is the ultimate blend of balance. So those are the three things that I wanted to emphasize that I thought were lessons for me in my 15-year journey. And I'd like to share with you that the ride is long, but quite enjoyable. And I'd be happy to answer any questions if there are any at the end. Thank you so much.
Thank you, Rola.
It's a pleasure to start the session on reflections, and I'm very excited to have my colleague, Dr. Ghaida Hassan, who is a clinical psychologist and professor of clinical psychology at University of Quebec in Montreal. Ghaida, please go ahead and tell us about the reflections on all what you've heard in the prior presentations, and from your point of view as a clinical psychologist. Thank you very much.
Thank you, Rola, very much, and I welcome everybody to today's session. I have a small PowerPoint to share with you that really summarize the reflections that I have from the previous sessions, and will concentrate on two very important concepts that we have in psychology, and these concepts are vicarious trauma and post-traumatic growth. The purpose of this session today for me is really to convey the importance of taking care of oneself as a healthcare practitioner. This is very important. And I would like to introduce the concept of vicarious trauma. So what is vicarious trauma? Vicarious trauma is the fact that as healthcare professionals, we are exposed to people, especially cancer patients that we work with, that have undergone a traumatic experience. We know that a diagnosis of cancer is traumatic. We know that the invasive treatments for cancer are traumatic for our patients. And we as practitioners, even though we can be very focused on the medical aspects, we are touched and moved by the suffering of our clients. And their suffering, their traumatic experience can suddenly become traumatizing to us. It's as if in an empathy, we feel the same trauma that they are feeling. And this is something we call vicarious trauma. This is a concept that's very well known in the psychology, in the mental health field. And mental health professionals, such as psychologists, for example, we are more and more involved today in the health field because we know that our patients and practitioners need the support. They need to take care of their mental health while practicing their physical, let's say, or medical health duties. So I want to show you today what are the signs of the beginning of developing vicarious trauma and how we can transform vicarious trauma into something that's very positive that we call post-traumatic growth. Vicarious trauma manifests itself in some reactions. The most common reactions that we observe are fatigue. I think today in the COVID crisis in the healthcare system, each one of you knows what fatigue means. Sudden disinterest or unwillingness, difficulty listening to the stories of our clients. Sometimes something that we call in psychology dissociation. This means feeling completely indifferent, feeling numb suddenly to what the people are saying, as if we kind of created a cut between our emotions and the stories that we're hearing. Diffuse anxiety, feeling worried about small things that didn't used to worry us before. Sadness, of course, and frustration, irritation, feeling of helplessness, facing maybe the suffering or the fact that our clients are not improving as the way that we wanted them to improve. I just want to tell you that these reactions are normal. They are not to be ashamed of. These are very normal reactions. These are common reactions when we work in this field, but they may lead to some tensions at work and at home, and they deserve attention. So they deserve attentions, particularly when they continue or when they become accompanied by these specific reactions, meaning intrusive and recurrent thoughts related to work. So you leave work, but work does not leave you. Then it's a sign that things are becoming a little bit more tiring, maybe a bit more traumatizing for you as a practitioner. Sleeping issues, loss of appetite, difficulty concentrating at work, at home, and greater anxiety and sadness. This is a time when you should not ask yourself 1,000 questions. You must seek help when you start feeling those emotions, because it means that you are on a track of vicarious trauma. And it can be resolved very quickly when you do seek help and assistance. So when you cross that psychological barrier of saying, I need to consult, I need to talk, I need to seek help. So how do we seek help? How do we take care of ourselves? We must take care of ourselves on a daily basis. I often see that resilience is like a tree. You know, a tree does not grow suddenly. Every day there is growth. And taking care of oneself, avoiding vicarious trauma, is really doing those small things every day that in the end will lead to a very positive qualitative result. So, of course, talk about your experiences with your colleagues and team while respecting confidentiality of the clients. That's definite. You can talk about with loved ones, but please careful not to overburden them with aspects related to your work that may be traumatizing to them. You need to take breaks, laugh, breathe, eat snacks, watch funny cat videos on TikTok or YouTube. And when it's most importantly, you need to exercise, you need to walk, you need to meditate or pray. So keep those moments where you feel that your body can where you can take out the stress from your body, but also from your mind and from your spirit. These are very important. What I'm talking about may seem very simple, but often the greatest solutions are in the simple daily practices. And beware of your limitations. If you find a situation particularly disturbing, if you become too concerned about a client, too tired to hear certain stories, if you feel fragile when facing some of your patients, this is something that we call emotional distress, meaning that instead of being able to concentrate on their health, on what they're telling you, you're actually more geared toward your own emotional distress at listening to their stories. Then do not hesitate to mention this to your team, your supervisors, professionals working with you. And do remember that pushing yourself beyond your limits does not actually help anyone. It does not help you, it does not help your patients, and it does not help your team. And within your team, you must start to think about a strategy, a plan to be able to be there for one another and adjust in terms of strength and limitations of each member of the team. So let me finish by saying, when you follow these recommendations, let's say, then you are transforming gradually what can be vicarious trauma into something we call post-traumatic growth. Post-traumatic growth is that stage where the experience of others, even when it's painful, can become a learning experience for you. When you feel that helping those clients is actually making you develop personal resources and contributing to make the world finally a better place, helping others in making their lives much better lives, even if the end result is an unfortunate one and a negative one, but it's helping them through that process to lead better lives. So when we follow this path, we will transform post-trauma into post-traumatic growth and then become more and more resilient as practitioners. So I'd like to thank you today for the time that you have given me in presenting that path together.
Thank you so much, Raida. This is amazing and a great message to professionals to take care of themselves. And thanks for providing these important tools. Very important to realize the magnitude of mental health burden during the crisis and how we really need that kind of balance, especially at work. And I loved how you also took it to another level where we communicate with the people around us, including the loved ones. Thanks again for your time, and moving on for the next session. Welcome to the session on leveraging multidisciplinary cancer care to empower patients and their healthcare providers. I'm so excited about this session because it's very important for patients' journey in cancer care, particularly for the breast cancer patients. We have wonderful speakers. We have a breast navigator, Lindsay Jastinsky, a patient advocate who's actually a pharmacist, but he's here in the capacity of a patient advocate and a caregiver for a patient who was recently diagnosed with breast cancer, Mr. Samir Qamar, and Dr. Abdullah Shuli, an oncologist. So we're gonna go first with the breast navigator presenting the role and the importance of breast navigation in the patient's journey. There you go, Lindsay, get started.
So I just thought I would start out with a brief overview of what patient navigation is. So as per Dr. Freeman, who is actually the pioneer of patient navigation in the 90s, it is a process by which an individual, a patient navigator, guides patients and their families through and around barriers in the complex healthcare system to help ensure timely movement of the patient across the entire healthcare continuum, from prevention, detection, diagnosis, treatment, and supportive to end-of-life care. Oops. this model here shows how patient navigation has expanded from the entire healthcare continuum, really supporting patients throughout that. But with the original model that Dr. Freeman used, it was for screening through to diagnosis and treatment of breast cancer. And that is actually how my role works where I work. So my patient navigation supports patients through what I call kind of the screening and diagnostic phase of the diagnosis of breast cancer. But really, a patient navigation program can include all the way from outreach to prevention, which some of my work does do that. We go out into the community to help teach about the importance of breast cancer screening and importance of breast health awareness with different community organizations, all the way through to survivorship and palliative end-of-life care. So sometimes through the relationships I develop with patients, I end up supporting women through survivorship. But when creating a patient navigation program, you just really need to define that end point. And so for me and for us at my department, the end point for us was kind of getting to that first line of treatment. But it really can be different for everyone. You just really need to make the patient navigation program to support the needs of the patients and the community that you're serving. So how can a breast health navigator help patients and their families? So I think the main success of the patient navigator role is that you have the dedicated time. That's my job. I'm there to support people. So you're not bothering me. And so having that dedicated time for patients that they know that they can reach out, someone will be there and you're not bothering them. So just a review of some of the things that I help patients and their families with on a daily basis. So answer questions and help prepare them for appointments. So I do book some specialty appointments with patients, so you're able to give a bit more detail about what to expect, how to prepare, who's going to be doing this for you. So I think that helps reduce anxiety and makes a more compliant patient. I help patients learn about their diagnosis and their treatment. When you hear those words of cancer or whatever diagnosis you're receiving, a lot of the after information is lost. And so just having someone that you could reach out to kind of maybe make sure you've understood that information, clarify anything, or say, that's a really good question to follow up with on your provider at your next appointment. So just somebody to kind of review things with another set of ears. I'm also there to help find resources and community supports for patients and their families. So, pointing them to reliable sources of information on the internet, also different community supports like peer support programs, or medical supplies, so for breast cancer like prosthesis and mastectomy bras. So just helping them navigate what's available in the community to support them. And just guiding patients through the healthcare system in general. It's very complex. There's lots of different people involved, different players on the healthcare team. So helping them understand whose role is what and who can help them with each of these things that they're worried about. Also helping them feel more in control of their care. So once you get a diagnosis, I hear a lot of, I feel like I have no control over my health anymore. And so just helping them gain a little bit of that control back by providing them with more information or expectations about what's next helps them feel a little bit like they have some control back in this process. Also assisting them to speak with doctors and staff. It's intimidating to speak with medical professionals. So just giving them a little bit of confidence to say, that is a really good question to ask, or that's a valid concern. You should bring that up at your next meeting. Or if they're still hesitant, maybe just being that in-between person that I can reach out to the provider on their behalf with their consent. And then just streamlining and scheduling appointments to try and make the journey a little bit more seamless and coordinated. Everyone's busy working or caring for others or living a far distance from the care center. So if we can coordinate in any way, it makes the process a bit more tolerable. And then I just wanted to touch a bit on multidisciplinary cancer conferences. So at our center and major oncology centers, I think it's pretty standard to have these types of meetings. As my role as navigator, I also serve as the coordinator for these meetings, and I see firsthand that they're very helpful for improving patient care. So breast cancer involves, or breast disease involves, several disciplines to get that diagnosis and treatment. We've got surgery, pathology, radiology, oncology. So having regular meetings where you can bring all these players together in a dedicated time where everyone has their attention to discuss patient plans is very helpful. For patients, it provides them with the confidence that a group of people have looked at their treatment plan and agreed with it or disagreed with it. So for them, it feels like you're almost getting second opinions without actually having to seek out a second opinion. So I've heard a lot of feedback from patients that they like that their cases are reviewed by multiple providers and the whole team. And then these regular meetings allow for quality issues to be discussed. So through conversation, different quality issues come up that can be addressed with the group all in one setting. So examples at our center that have come across are pathology specimens being inked in the OR and how that impacts positive margins for re-excision rates and such. We've also seen feedback about radiology reports and how maybe they can be tweaked or improved for better understanding of the providers. And I think it just is another opportunity for discussion about how the program can be enhanced, maybe new technologies or different pathways that the patients might benefit from with this group discussion. And it lets providers see how others deliver care in a non-judgmental environment and maybe change their practice a bit. And lastly, I just wanted to talk about how my navigator role, I think, really helps to empower patients on their healthcare journey, which I think is so important. Three things that I kind of always talk to patients about and things that come up are, you must be your own advocate. You know your health and your body the best, and you're the most valuable player on that team. So if you can't be your own advocate for whatever reason, then having a support person, family or friend that can be your advocate is also very beneficial. So I help sometimes in those situations. Get to know the players on your healthcare team. So because it's so complex, breast cancer and breast disease, knowing who all those people are on your team, knowing their role, where they work, jotting their names down. So I often help patients, create a journal for keeping track of all of this. And then lastly, being an active participant in your healthcare. I think historically patients maybe have played a more laid back role in this, maybe just doing what patients or what surgeons or providers tell them to do, but now patients are wanting to be more active in their care. So I help them to do that, encourage them to do that, but also let them know that take the time to listen to these providers. They are the experts in their field. Go in with an open mind, but then also voice your concerns and make sure that your fears and anxieties are addressed as well, and that you feel comfortable with the proposed plan. So patient-centered care, I think, leads to better patient satisfaction and overall better health outcomes. So I always empower patients on their journey. And that's all I have to say. Thank you.
As you said, it's important for patients to feel that they're back in control and take away that intimidation, capturing all these quality issues, and even helping the healthcare providers understand each other. So thank you so much. More to reflect on. We're going to move on to Samir. Samir, as I said, has a pharmacist background. He's a lecturer at University of Toronto and professor at Fleming College in Peterborough. But he's here today in his capacity as a caregiver, and he's going to share with us his experience and highlighting the important role of multidisciplinary care in the patient's journey. Go ahead, Samir. Thank you.
Thank you, Dr. Shaheen, for the introduction. Thank you, Lindsay, for your presentation. Essentially, I do just want to echo what Lindsay's presentation was all about, but from an anecdotal or personal experience with a family member that was recently diagnosed with breast cancer, who happens to be my mother. So I do want to start off by stressing two very important points, and that truly is the importance in the fidelity of a robust multidisciplinary cancer care team approach toward the care that my mother received, and domino effect of how other patients' cares are received as well. And two would be how early cancer detection and screening can both save lives and improve quality of life. And I want to stress the importance of how early cancer detection and screening can both save lives and improve quality of care. So the family member, in this case, my mother, was part of the high-risk breast screening program. Despite her being reluctant or emotionally nervous before each every 6-month appointment, we fortunately had a strong multidisciplinary cancer care team that stressed the importance of screening. And then once mom was diagnosed with breast cancer after the initial biopsy, you'd be surprised how quickly things progressed, despite it feeling like a lifetime, of course, for my family and myself. What was comforting was the amount of multidisciplinary cancer care clinicians that were involved in her care right off the bat, similar to what Lindsay was saying. We had initially the radiologist, referred to the breast surgeon, referred to the medical oncologist, referred to the radiation oncologist, and of course, throughout the entire journey was the breast navigator, the patient care navigator like Lindsay, and then myself as a pharmacist caregiver and family physician. And it's fascinating because all of the above have unique individual roles, yet the overlap in care or redundancy in care and in our healthcare system, I think, is what can be very reassuring for the patient, and it was for my mother. Especially what Lindsay was saying, which is that during the multidisciplinary cancer care team rounds, knowing that you have sort of an all hands on deck approach where everyone is consulting with the care of the one individual patient. As a result, thankfully, mom did not need chemo nor radiation. And this is huge because the results are so profound. It means that the prognosis was favorable for my mother, which hopefully translates to longevity of life and enhanced quality of life, because both are equally important, I would argue. All of this, and mom still required a mastectomy. So please, if you're to remember one takeaway, it's that early cancer detection and screening in the context of a multidisciplinary cancer care team approach can literally save lives and enhance the quality of life of your patients. And I want to end by mentioning even in Lindsay's final screen there about having support with the patient care team and the two hands there. Sometimes it's fascinating. You'd think that the hand that someone needs to hold is an elderly person's hand. But in this case, mom, at least I think, is quite a young patient, and yet this happens. So cancer doesn't tend to differentiate between age, unfortunately. And so the importance of having a supportive, not just multidisciplinary care team from the clinical side, but from the family side and friends side, and being supportive as well, I think goes a long way. Thank you so much.
Thank you very much, Samir. This is very empowering message. I really appreciate sharing your personal and your family experience with us. It's very important for patients to have this kind of support and to understand the important role of the multidisciplinary care. I appreciate it. Now we're moving on for another perspective, the perspective of a physician who sits on the multidisciplinary care and have to make decisions and influence colleagues. Dr. Abdullah Shuli. Dr. Abdullah Shuli is an oncologist who is the regional director at the University of Pittsburgh Medical Center. And actually, our friendship and collegiality goes back a very long time ago. We went to the same medical school at Jordan University, and I have been sending consults to Abdullah all along my career, and I really appreciate it. And here I am asking you, Abdullah, to give us your perspective on the importance of the multidisciplinary breast cancer care. Thank you.
Good morning, everybody, and hope everybody's having a very good Sunday morning. So just to echo what Lindsay said and what Samir said, it's such an important factor to have a multidisciplinary team that will manage any newly diagnosed or any diagnosed breast cancer patients. And that extends from the whole, as Lindsay mentioned, the continuum of the breast cancer care. And it highlights the importance of the screening, the diagnosis, the treatment and the initiation of treatment, and the follow-up afterwards, and the surgery, and to ensure that those things get instituted and delivered in a timely fashion that it doesn't impact the long-term outcome for the breast cancer care. And back to Samir also, and it's not only the elderly, as mentioned, Samir. I had, over the course of the last 18, 19 years, I had patients who are 18-year-old, in their 20s, in the 30s. So it could, I mean, it's a disease that could affect really any of us, all of us, men, women, and it's very significant, can cause significant morbidity, and can affect your health, your lifestyle, your outcome, how you deal with your family, your financial situation. It's such a significant disease that it really requires that most attention and concentration of all the efforts to treat the disease. In our multidisciplinary cancer center and the conferences, really, as Lindsay kind of alluded to, consists of a whole lot of people. So you have the breast surgeons, you have the medical oncologists, and then I say an S, multiple oncologists, radiation oncologist, radiology, nuclear medicine, pathology, social services, physical therapist, nutritionist, and the survivorship program, and the research team. And that we meet pretty much frequently, sometimes usually not for the breast cancer, but for all the other tumors, but for the breast cancer, usually on a monthly basis as an official conference. But the smaller conference that happens between us and the surgeons and us and the radiation oncologists, it's such an important role in management and treatment of breast cancer. It's a huge fact to deliver a huge effort to offer people multidisciplinary cancer care. And it's not available everywhere. And what concerns everybody is the fragmentation of services. So, I mean, you can actually try to mimic it if you're in a community and have no access to a multidisciplinary thing to reach to. You can see the oncologist on your own, the radiation oncologist on your own, the surgeon on your own. And that, even for me, living in the United States, still happens in a lot of communities. People do not have access to cancer centers that frequently. Although we do have a pretty high rate of screening, every now and then you'll see people who really either do not have any screening based on either financial reasons, personal reasons, for whatever reason. Every now and then you'll see a locally advanced or somebody who's presented with metastatic disease and had this disease going on for so long. And a lot of time it's a complicated issue why a patient with cancer would not voice their concern about a lesion that they felt in the shower or something they noticed. It becomes more of a fear and anxiety, and they try to hide it. Actually, my own mother-in-law died of breast cancer, and she had a very locally advanced breast cancer that literally destroyed her breast before she mentioned anything. She eventually succumbed to her disease, and it was a very traumatic thing for her daughter and her family because she was in her 50s. So it's very important to focus on the screening, because that's, I think, the key in preventing complicated and delayed services. The earlier the disease, the better the outcome. And I think that takes a lot of effort from the health providers, from health systems, from insurance companies, from patients, from easy to access from patient to health services, advertisement, do a lot of campaigns. I mean, and even locally here in our community cancer center, we actually had a whole campaign of having a mammogram for like $30 or $50 for somebody who doesn't have insurance or does not afford to go. Again, remember, this is the United States, not Canada, where health services or health is not insurance is not for everybody like you guys on the north of us. So again, back to the issue, it's a complicated issue to treat any case of breast cancer, early or late. But from the oncology perspective, when we see the patient, usually the patient show up with a lot of preconceived notions of what cancer is and what's going to happen to them, and am I going to live this or not? And we forget how easy people have access to information anymore. There's almost like a data overload. Access of your finger literally on your phone. All you have to do is put Google on breast cancer, and God knows what you're going to get. And a lot of people show up with either a lot of information, and some people do not show with no information, with just with their fear, and usually with their family members. And you can tell the moment you walk in the room how anxious they are, despite they've seen a surgeon, a nurse navigator, had a diagnosis and all that stuff done. They still do not sure what's going to happen to them. And I think a lot of people fear also the possibility of the use of chemotherapy and radiation, and how is that going to affect me, and so on. And of course, what people also get nervous about is how much I'm going to throw up. Am I going to lose my hair? I mean, I lost mine. I'm not complaining about it, but it's a big concern for a young female or a young male. Or any human for that matter, if they don't want to lose their hair, how is that going to affect me? And you start to slowly kind of explain to them how the process goes, what do you have to do, and based on the presentation, we'll decide what we're going to do with the patient. And afterwards, they meet with our nurses, with our nutritionists, the social workers, and if we can decide to do chemotherapy in our place, we offer them the use of cooling caps so that they do not lose their hair, which is an amazing thing that is kind of available anymore. Patients with breast cancer don't have to lose their hair. And you would not imagine how significant that is in a lot of people. We actually get a lot of the patients come to see us just for the possibility of not losing the hair. So it's quite significant, really. We want to divert a lot from the topic. Back to the multidisciplinary care. It's a really, I think it makes a difference on the outcome. It does affect on the delivery of services, how fast patient can be treated, and it gives the patient themselves a lot of knowledge about what the disease, the outcome, what to expect. And I always tell patients, knowledge is power. If you know, it's better than that you do not know. You need to know what's ahead of you. You know what the disease is, how aggressive it is, how is that going to act, what are we going to do about it? And even that, people still kind of go and venture on their own and look on the internet, and we know what the internet brings us. We all experience that with the current pandemic. So it's a very complicated issue. I think if a patient having access to a multidisciplinary cancer center, it's probably much better for them. We're gonna have to think of people who have no access to it. What are we gonna do with them? How can they make this the standard of care everywhere? Sadly, it's not everywhere. Those are issues obviously for the future, and it probably a lot of things will dictate how we get to that point. I think I'm gonna just hold here, and you guys can ask me things if you want to.
Thank you so much, Dr. Shuli. This is very nice overview. Probably I'm gonna push a little bit here and ask, as you said, a lot of patients have access now to information, actually most of them, and they come with a lot of concerns and anxiety and probably different opinions. How do you feel that the multidisciplinary conferences that happens to discuss patients, can they actually resolve that kind of anxiety and the fact that patients comes in with a different opinion from what's proposed as a treatment plan? What's your experience with that? Like, how can you, do you feel that the fact that it's, as Samir said, the fact that there were so many people giving a lot of information with some redundancy helped the patient navigate through the process, but what's your experience from physician's point of view?
Well, we all know that what patients want is, what a patient really wants is to get the disease treated. So that's the ultimate goal for the patient. As Linda said, they're the MVP. They're really the focus of the attention. And I think a lot of times, as I said, it's the ease of access to that information for everybody. Sometimes maybe it's not on our side, maybe helps us in the wrong way. Maybe it's a good thing, it's a bad thing. But when you meet with your surgeon, when you meet with your oncologist, with the radiation oncologist, with a social worker, with a few nurses, with the nutritionist, the physical therapist, and they all echo the same information that I mentioned before, somehow give the patient a lot of confidence, and that's probably the right thing to do. I would imagine and again, it's also how fast can those things get delivered to the patients makes a lot of difference. You don't want to wait like 4 months to have a procedure done. I mean, nobody does, but I'm giving this just an example. The fragmentation of services and the delay of services is a huge thing. And I can tell you, one of the things that I get asked about probably on a daily basis, is this like week late or 2 weeks going to make a difference on my cancer? Is that going to become, is it going to go everywhere? What's going to happen in those 2 weeks? And you have to explain to the patient, sometimes it's, nothing will happen in 1 to 2 weeks, but it's that anxiety that drives a lot of patients to either to look somewhere else or to have a lot of, to listen to their neighbor, believe it or not, more than they'll listen to you, believe it or not. And it's a fact also that patients will tell the nurses more than they will tell the doctors, especially when they're on active treatment. It's somehow they want to hide the real information from doctors because they think that will affect the treatment. They will not be treated as aggressively. So you do not. So though all those preconceived notions that patients need to overcome initially, and I think having that multiple opinions offered to the patients from more than one part of the service help to focus on the right thing and avoid the confusion and the delay and the fragmentation of services.
Thank you very much, Abdullah. This is great consistency in the message for the patients, and having access to different backgrounds of healthcare providers help bringing what the patient is trying to say, even in a non-intimidating atmosphere. Well, here we come to the end of this session. I'd like to thank you all, Dr. Shuli, Lindsay, and Samir. It's been great to have this kind of discussion. Thank you.
Thank you, everybody.
It's wonderful to start another important session where we're going to talk about art meets science, gratitude, clinician and healthcare professional engagement in funding the advancement of cancer care. The session will be led by Leslie Highway, the president of Peterborough Regional Health Center Foundation. Leslie will be sharing with us the role that philanthropy and donor investment plays in advancing cancer care, how expressions of patient gratitude play a central role in the healing process, and how the healthcare professionals can participate in this joyous work while helping their hospital advance, or their healthcare center, its vision for the delivery of cancer care. Leslie, it's great to have you here. Please go ahead.
Thank you so much, Rola. Hello, everyone. It's so great to be joining you today. I'm really excited for the opportunity to share the role that philanthropy and physician and healthcare professional engagement and gratitude play in funding the advancement of cancer care. Just a little bit of background on the foundation I lead, as I know that our audience is abroad. So our hospital and our foundation are located 2 hours west and north of Toronto, here in Ontario, Canada, where hospitals have foundations that operate as separate entities and as independently incorporated entities. Hospital foundations are charitable organizations operating under government oversight. Our mission is to raise the funds required to ensure equipment, technology, and programs remain strong and viable. Donor investments help drive the vision for a hospital's clinical programs forward here in Canada and in the States. In our case, we have an incredible partnership we've formed over the years with our hospital partners, and we work together in really close alignment. We also work very closely with our chiefs and our medical directors, our physicians, and our nursing leadership. Peterborough Regional Health Centre, the hospital my team supports, is a 480-bed acute care hospital serving a patient population of up to 600,000, and it's the regional center of excellence for cardiac care, cancer care, and vascular care. As a regional center, we also support several smaller partner hospitals who refer to us for their regional programs mentioned previously, including cancer care. I'm just going to share my presentation here with you. On the foundation side, I have a small but mighty team of 11 raising funds through a variety of mechanisms defined as best practice in our sector. We have 11 different programs through which we raise funds, including our direct mail program, where we have thousands of donors who support through the mail. We have a rapidly growing online donor presence, and we have events like signature golf and signature galas, third-party events where other individuals raise funds on our behalf. And because we're the second oldest community in Canada, we have donors who donate gifts or make gifts through their estate plans or through their wills. And that's a significant portion of our donations. So today we're in the middle of a $50 million campaign that will touch the lives of patients from across our region. Specifically, we're raising $15 million for cancer diagnostic equipment and technology. So with that as background context and having painted a little bit of a picture for you, I'm going to dive right into the presentation. I thought it would be helpful as a starting point to define the word philanthropy and the role that it plays in funding healthcare advancement. So philanthropy by definition is the love of mankind. It's a focus on the bettering of the world for others, often expressed by the desire to donate funds. However, philanthropy extends well beyond the financial realm, as you'll see shortly. Just a few thoughts on the role of philanthropy in the healthcare or hospital environment. So I'm going to begin with the obvious. Philanthropy as it is a financial imperative here in North America and in many countries around the world. Philanthropy is no longer just a nice to have, it's a need to have, and it has been for decades here in Canada, in the US. Here in Canada, the government funds a portion of hospital operations, but it does not fund the equipment and technology needed to deliver world-class care. After 24 months of pandemic revenue reduction, donations have never been more important than they are now. I work very closely with our hospital senior leadership on their short-term and long-term planning processes so that I have a very clear understanding of the short-term equipment and technology needs of our hospital 5 years into the future, 10 years, and even 20 years out. The role of my organization is to play a key role in funding this vision. Community transparency around this is so important, and that's why our hospital takes the lead on planning. I can always turn to the community to say, these are the hospital's top priorities as they've defined them for us. The hospital board has approved them, and this is the vision from which we work. So although the financial role is an important role, it's only one of the key roles. An equally important role is that philanthropy connects our hospital to the community every single day, through every mailing we send, through every conversation, through every service club we engage, and every donor we speak to. Every touch point my 11 team members have on a daily basis on behalf of the hospital, in engaging with key stakeholders. The physicians we engage with are helping us to share this messaging about critical investments required to take our hospital's programs and vision to the next level. And as you'll see in a minute, physicians and healthcare professionals do play a very key role in sharing this vision ahead in partnership with our organization. One role you may not have considered in terms of the role of philanthropy is as a catalyst for health equity. So more and more, our role is to have courageous conversations with our donors, your patients, about inequities and to work to address these through the development of new programs and services. So today, as part of our work, we're raising $4 million to bring a new mental health and addictions crisis unit to our emergency department. Physician and healthcare professional expressions of patient gratitude from your patients are donors who wish to honor the work of the healthcare team. They wish to share their positive thoughts on the care they received and make a gift in their honor. There's so many critical components of the health system's work now intertwined with the work of the philanthropy team, and with this comes the recognition of philanthropy as a strategic imperative. In American hospital environments, the most senior person responsible for philanthropy typically has a seat around the senior leadership table. Here in Canada, we work in strong partnership, and I lead a separate entity, but I'm very closely connected to the work and the vision of the hospital senior leadership team. In a moment, I'll share a short case study of our work in partnership with physicians and the significant role they've played in our community's desire to invest and to donate into new technologies that supporting cancer care at our hospital. But I thought first I'd share some recent successes resulting from physician and healthcare professional engagement and gifts of gratitude. So just a few milestones that I wanted to share with you today. In 2008, our new hospital opened, and that was the amalgamation of 2 hospitals into one. And really that was our brand new cancer center, significant support of donors, causing that to come to fruition. Between 2011 and 2013, we ran what we called our Closer campaign, bringing radiation treatment closer to our hospital for the very first time. In 2014 to 2019, donors supported millions of dollars in vital investments in cancer-related labs, surgical DI technology, ensuring faster, more accurate, less invasive cancer diagnosis and treatment close to home. 2016 to 2019 represented a $1.9 million investment in 3 new state-of-the-art mammography machines. And we're going to hear a little bit more about that in a moment. In 2019, our hospital took a significant leap forward in nuclear medicine, largest leap it had taken in more than a decade, bringing a brand new SPECT CT to our hospital for the very first time. So now I'd just like to take a moment and turn our attentions to the specifics of patient gratitude. And there's a few things I'm really excited to share with you in terms of how your grateful patients, who are ultimately our donors, express their positive feelings for the healthcare team. Before I move on to the next slide, patient gratitude, I have to share this. Patient gratitude is a field of study that's been very well documented, carefully studied, and I've got my references at the end of my slides. For hospital foundations, patient gratitude is literally our life's work. The truth is that nearly every donation we receive begins with one of your grateful patients. It's an entire field of study devoted to how physicians and healthcare providers can best engage with patients to truly understand their expressions of gratitude. What I will share are a few facts for your consideration. So what you see here are donor motivations for giving, coming from a place of gratitude and what we call the healing cycle. So you can see here that when patients express their gratitude for the wonderful care they've received, this gratitude leads to giving. It creates happiness on the part of the patient and very often on the part of the physician. Happiness leads to healthier behaviors. And we also know that this gratitude has a very strong linkage to engagement, to donations, and a wanting to give back. Here's an interesting fact. The reason people feel gratitude in the healthcare experience are not always closely connected to their clinical outcomes, and this may come as a bit of a surprise. So while hospitals measure outcomes very carefully, as they should, outcomes are not a primary driver of the patient experience, nor of their expression of gratitude. So while healthcare providers may view their interactions with patients as part of their daily routine, patients interpret your talent, your dedication, your communication, and your actions as truly extraordinary. And as a result, patients develop deep gratitude for their healthcare professionals as part of their healing process. So I know that might be a bit of a new idea, gratitude as part of the healing process, but it truly is. It's foundational to the physician and patient relationship, as noted, and it's absolutely foundational to the role of philanthropy. And this has been extremely well studied. So I wanted to share a few thoughts of the intersection between patient gratitude and the healthcare team. Patients who have a positive experience do often want to express gratitude. Patients who wish to express their gratitude, have it received correctly, and can complete the act of saying thanks are happier with their healthcare experience. And on that note, healthcare professionals who better understand why and how patients need to express gratitude are more likely to receive it in an appropriate way so that the patient feels heard and acknowledged and is directed in a meaningful way. Patients who experience happiness and gratitude often have healthier behaviors than less happy people. And the philanthropy office and the team, people like myself, we do want to engage with grateful patients who are interested in the healthcare organization and the value that it offers to the community. And of course, we realize that not all grateful patients want to donate money or funds. We're able to guide donors in the area of gratitude most suitable to them. That may be volunteering at the hospital, donating food to the healthcare team. We saw oodles of this during the pandemic period. Thank you messages, tribute gifts. In order to have this interplay between physicians and the philanthropy office in place in a hospital. There are certain mechanisms that are needed in order to support this activity. And it does take several years to establish an approach to giving. It's an entire organizational culture that's needed to underpin this so that the role of philanthropy is well understood, has the support of senior leadership, there's accountability, and the philanthropy office is recognized as a core function of the healthcare environment. So the role of physicians and healthcare professionals, how can you help? How can a physician or a healthcare professional be engaged in the work of philanthropy and in the work of supporting the next era of healthcare investment in cancer care? You play a key role in helping shape the vision, the growth of programs, and all of the foundation's work really stems back to physicians. And we spend a lot of our time when we understand what the hospital's priorities are in ensuring we can articulate them to the community. It's your language we're taking forward in building a case for support that's inspiring and that's going to engage the community. And through this process, we've built so many trusted relationships with healthcare providers. When their patient turns to them, or when your patient turns to you and says, "How can I help you?" they're often referred to me or my colleagues in the foundation office. And really that comes after a number of years. We know it comes from a place of trust, from relationship building, and having physicians and healthcare providers know that the philanthropy office can be an extension of your work. We will listen to your patients, treat them always with the utmost of respect, and help them to fulfill their expression of gratitude in a way that's meaningful to them. And we will build trusted partnerships with you and partner with you to help share your work. And I'm going to share a slide in a moment that demonstrates all the different ways that we've worked together with our physician community. So this collage slide it shares a couple of examples of physician engagement that my office has undertaken. So you'll see house calls. House calls was a virtual event. In the face of the pandemic, we weren't able to meet with our donors. It was a virtual event that we hosted. On that invitation, you'll see our hospital CEO, our chief and medical director of mental health services, our director of mental health services, and myself. And in partnership, we were sharing in this particular event, the vision forward for a mental health department. In the middle, you see a group of donors and myself all scrubbed up in one of the operating rooms, and our chief of surgery, who's an ophthalmologist. And we had at one point 44 different service clubs, and each service club had about 30 individuals raising funds and really engaging the community in helping raise funds for a brand new phacoemulsification machine at the hospital. And we worked very closely with the ophthalmology team. The gentleman in the circle, Dr. Fadi Abdel Saeed, we worked with a lot last year, and he identified a few patients for us, his patients who had expressed their gratitude to him, who were willing to share their stories. And so what you see in print with Fadi's photo on them, those are some direct mail pieces that we sent to our donor base, engaging them in Fadi's work as an interventional radiologist, because we have to raise $6 million this year to re-equip 2 new interventional radiology suites. So that just gives you a synopsis of just this last number of months, really. Bit of a case study here on our breast assessment center and the work that we did in working with the team at the breast assessment center on bringing new 3D mammography to Peterborough Regional for the very first time. So when this became a key priority for our hospital, and we knew we needed to replace our 13-year-old mammography machines, I reached out to Dr. Shaheen for her assistance. She introduced us to the healthcare team. They helped us participate. They spoke at many of our events. They led many donor tours. They helped us write to our donors and share the impact that these 2 new mammography machines would have for our patients. Over the last 10 years, much of the technology in the breast assessment center has been funded by our donors. They have new radiology workstations, ultrasound, voice dictation, and we're currently working to fund MR guided biopsy. You'll see the ladies in the boat. That's called a dragon boat. That team alone has raised more than $3 million over the last 20 years to bring much of that new technology to our hospital. One key piece I'd also like to share is the role that donor funds and the role that donors play in physician recruitment and ensuring that we have that world-class technology and ensuring that when physicians are interviewing at our hospital, they have an opportunity to see the technology, because we know that physicians and healthcare providers want to be able to deliver the very best possible patient care. So technology does play a key role in that, and by definition, as does philanthropy. So I really want to thank everyone for the opportunity to share a little bit about the role of gratitude and the intersection with clinician and healthcare professional engagement in funding the advancement of cancer care. And I'd like to leave you with this short 2-minute long video and a story shared by a patient, 32-year-old Amy, who is a dragon boater in that boat. She was identified by one of our physicians and she received her diagnosis in our breast assessment center. Her expression of gratitude was to share her story, helping us engage others in funding the next level of care. And we shared the story on TV, radio, in person. And this is how she wanted to give back for the great care she received, to make it better for the next person, truly for the love of mankind.
I just kept saying, I don't want to die. I just don't want to die. I will do anything. You're almost pleading with whatever's going to happen. It still startles me how everything just stopped. We are high school sweethearts, so we've been together since I was 14. We would lie in bed and I would be worried and I said to him actually once, and it was one of the hardest things, but I truly meant it. I said, this is going to get bad. And if you want out, you have to go now. Yeah, you try and spare people the hurt, I think. I remember vividly walking into the breast assessment center the first day. I was quickly made aware of all of the different areas of the hospital that are used by a cancer patient. It is unbelievable the magnitude of tests that they have to run to support your survival. I think having the PRHC and the Breast Assessment Center close to me was immensely important. I had my surgery there for my mastectomy. I did my chemo there, my MRI, my CT scans, all of that stuff was in one building. We have great equipment and we're getting even better state-of-the-art equipment all the time at the PRHC. I go every year for an MRI as well as a mammogram. We keep an eye on it, but because it was stage 1, it looks like I should have a good prognosis to live a long and healthy life.
So thank you so much for listening today. It was such an honor to have an opportunity to present on physician and patient gratitude.
Thank you so much, Leslie. This is amazing, and thanks for sharing your work experience. And honestly, the favorite part was the circle of gratitude and how it's closely connected to the circle of healing, and you showed that really nicely. Thank you for your time.
Thank you so much, Rola.
It's a great pleasure to start an important session, and I'm just going to share the screen. It's on ethical dilemmas in cancer care. This is a very important topic that has a wide spectrum of topics, and we run into it on a daily basis as we deal with the cancer continuum. However, we're now narrowing it to some different perspectives, such as in pathology, radiology, and chemotherapy suite. You're going to be hearing from my colleagues, Dr. Maysa Al-Husseini, Dr. Jean Seeley, and Karen Perrin. Without delay in the introduction, I'll let them speak about themselves and their experiences and what are their cancer dilemmas.
Okay. Thank you very much, dear Rola, for giving me the opportunity to be among this wonderful group and to speak about an important issue in cancer care in general, and probably in my case in pathology in particular. I will be tackling the issue of privacy and confidentiality, but first of all, I would like to share with you a little bit of myself background. So I'm a pathologist, the chair of the Institutional Review Board, which is the Research Ethics Committee at King Hussein Cancer Center in Amman, Jordan. And I've been recently assuming the role of a lead for the ethics, patients' rights, and patient-centered care cluster. So as a pathologist, what I do is actually rendering the diagnosis from biopsies or small pieces of tissues performed and submitted to the pathology for reporting. So for example, if Dr. Rola would encounter a case of breast carcinoma or suspicious breast mass, she will attempt to take a biopsy, and this biopsy will be sent for us to diagnose under the microscope. My second role is actually the chair of the institutional review board or the research ethics committee. So this is a permanent committee, what we call a standing committee at King Hussein Cancer Center, that pertains to maintaining, approving research proposals prior to inception for any kind of research at KHCC, and a primary goal is the ethical perspective of any type of research performed at KHCC. My third, more recent role is I'm leading a cluster that looks into the ensuring ethical contact and communication with patients, cancer patients, receiving treatment and management at the King Hussein Cancer Center, ensuring that their rights are preserved and that the patient is at the center of our care. Now, the main two issues that I would like to tackle is actually are considered a pillar to ethical management of patients, whether this is in clinical care or this is in research, which is privacy and confidentiality. Now, some time ago, we introduced two cartoon characters at King Hussein Cancer Center that belong to considered to be like members of the IRB. And the idea is actually to outreach to researchers, to the public, and try to introduce some of the ethical terms that we use, whether in research or whether in clinical care, in a more understandable fashion. So please meet our Zakan and Zakana, who are two junior doctors, personally members of the IRB. And one of the issues that we tackled initially when we started our outreach program is to try to help people differentiate and understand the difference between privacy and confidentiality. So privacy essentially is the control over the extent, timing, and circumstances of sharing oneself with others, while confidentiality refers on how the participants' identifiable data, like the name, the medical record number, the pathology record number, the email, the date of birth, are documented, handled, managed, and if needed, disseminated. So essentially, privacy deals with collecting the data directly from the patient, from the research participant, while confidentiality is related to how do we protect the collected data from misdistribution or misuse. Both terms are certainly interrelated, but they complement each other, but they are not synonymous. So talking about ethical issues in pathology, in particular in privacy and confidentiality, where we don't directly encounter patients. So the issue of direct contact with participants and preserving their privacy is not major in pathology. What is really important in pathology and in cancer in particular, whenever it comes to diagnosis, is maintaining confidentiality. And I'm going to share with you a small encounter that happened with me a few years ago. We had a colleague who is non-physician, non-medical, who came into my office asking me to provide him with the result of a breast biopsy for the neighbor, for his neighbor, upon the request of her brother. Of course, I denied the request. He did not feel happy. He thought that what would be wrong with sharing the results of a breast biopsy for their neighbor. So essentially, pathologists would share the results only with the treating physician this is made available on the electronic medical record of patients, or we share the results with the patients directly. We do not share the results of any of our reports with anybody other than the patient or the next of kin, if this is really within the context, the appropriate context and appropriate informed consent signature. When it comes to patient care, of course, privacy and confidentiality become major issues. And a common example that I usually allude to in my presentations, and because this is what I sometimes encounter, is whenever a patient walks into the clinic of a physician, the door sometimes is kept open. People outside walking just by might hear what the history of that patient is, what are the complaints, and this is a good example of how a privacy might be breached. When it comes to confidentiality, of course, we're talking about the clinical data that are present, collected in the course of the clinical care within the electronic medical record. And again, an encounter that a while ago happened to, I was passing by and there were two junior physicians working in front of me, and they were talking with names about the patients and the night call and the night shift and what happened and so on. So this was really a clear, perhaps this a clear, in a way, a breach of confidentiality. And of course, I wouldn't think that junior physicians would do so intentionally, but certainly approaching those junior staff and trying to teach them about the importance of keeping the confidentiality of the patient comes very important. When it comes to research, again, the same applies in maintaining privacy and confidentiality. Privacy, for example, if there was a common example that I always share is distributing a questionnaire, trying to reach out for participants or patients in the waiting area, asking them to answer a questionnaire that sometimes might have some sensitive questions like family history of cancer or the way they perceive the cancer diagnosis. And certainly, we always ensure to communicate to our researchers that collecting data for research purposes have also to be within the context of a private place, a private room, a private clinic, in which the patient or the participant is able to share the answers and communicate the experience. And of course, again, once we collect the clinical data that are sometimes maintained within the electronic medical records of patients for purposes of research, we have to maintain, to make sure that these data that are collected as research items are not linked to identifiers like the patient name or the number and are not made public, for example, in the medical library in the center or in the cafeteria, for example. So how to tackle the issue of privacy and confidentiality within the context of cancer care in hospitals at King Hussein Cancer Center, for example, I believe is reaching out through education, increasing the awareness of the stakeholders becomes very important. And certainly what we really don't have, but is present in other countries are regulations and legislations in which the privacy and confidentiality of the patients and participants in research are well maintained. Because if this is really breached, if privacy is invaded and confidentiality is breached, there will be important consequences on the relation between the participant, between the patient and the institution or the treating physician. And this would be, this might lead to loss of trust, which is considered an important pillar for the relationship between participants, between patients, and between the other stakeholders within the medical body and medical system. Thank you very much.
Thank you very much, Maisa. This is great experience that you have shared with us, especially if cultural impact the cancer care. So thanks for sharing that example. We'll reflect on it definitely in the questions and answers session. We're going to start with Dr. Jean Seeley, who is going to give a perspective that we always probably don't really pay great attention in the big picture. However, talking about breast cancer screening is a hot topic nowadays, and we really need to understand what's going on. Go ahead, Jean. Thank you so much.
Thank you so much for the invitation to speak, Rola. I'm going to speak about ethical dilemmas in breast cancer screening. These are my disclosures. Really, I'm going to focus on the one major objective, which is to understand some of the misinformation that has been promulgated to limit access to screening women 40 to 49 years of age, and apply it to how it affects Arab women in particular. So we have 30 to 40 to 50 years of experience showing that screening with mammography saves lives from breast cancer for women all ages 40 to 74 years of age. And these are the randomized controlled trials where lumped together, there's an over 24% benefit of reduction of breast cancer mortality. If we look specifically at women ages 40 to 49 years of age, if we look at the 6 randomized controls trials that showed a benefit and we lump them together, there was a 26% reduction in breast cancer mortality if we did not include the Canadian National Breast Cancer Screening Trials. But if we include the Canadian National Breast Cancer Screening Trials, that benefit is reduced to 18%. So there's no basis scientifically that says that 50 is the major cutoff. In fact, if we look at the number of women recalled under 50 and over 50, it's the same percentage overall, around 10% in the US, and in Canada, very similar. The number of biopsies recommended is no different at age below or after age 50. And the yield of cancer from a biopsy gradually increases with age, but there's no dramatic change at age 50. So if we look at these randomized controlled trials, the weight of evidence shows that screening mammography saves lives for women 40 to 50 to 60 to 70. So the only 2 outliers were the Canadian National Breast Cancer Screening Trials. What were these trials? They were 2 randomized controlled trials done in the 1980s in Canada across 15 centers across the country. The CNBSS-1 was for women 40 to 49 years of age, and the CNBSS-2 was for 40,000 women 50 to 59 years of age. And they were done differently. Women were volunteered to participate, and they all underwent a clinical breast exam, and then they were allocated to either screening with mammography or usual care in the CNBSS-1, or in the CNBSS-2 to screening plus clinical breast exam every year, or clinical breast exam alone every year for 5 years. So to do a proper randomized controlled trial, you have to have a blinded randomization. Otherwise, the allocations may not be truly random. And this is what happened in the CNBSS. So if you look at a large group of women targeted for screening, you should know nothing about the women that would compromise the random allocation. Some women in red will develop breast cancer. And if you allocate and randomly divide them, there should be the same number of women with cancer in each group. And that would be a successful randomization. They would develop breast cancer over the same number over the same period of time. And the same number of women would be expected to die from breast cancer over time. If you screened and it was successful, you would have fewer women dying in the screened arm than the non-screened arm. But what happened? In the CNBSS, there was a bias of the randomization, and more women with breast cancer were allocated to the screening arm than the non-screening arm, and more women died in the screening arm than in the non-screening arm. So how could this happen? What happened is that all the women were examined before they were randomized. So the nurse examiners would know who had lumps and who had large axillary lymph nodes. The allocation was done on open lists so that the nurse examiners only had to skip a line to ensure that women got into the mammography group. Many of these women knew these women and were trying to help them. So it was done with a good intention. So what were the problems of this CNBSS? First of all, and there are many problems, but we'll focus on the ones that they had lots of symptoms. So because they recruited volunteers, Women had symptoms of breast cancer when they came in. So it wasn't so much a screening study as it was a diagnostic study. And in fact, more than half of the women in the CNBSS and half in the CNBSS2 were actually clinically palpable in the screening arm. And if you compare that with an average screened population, only 15% of breast cancers are diagnosed by clinical breast exam. And there's no attempt made by the authors to exclude these women. They wanted to have a bigger power of more women with breast cancer. Now, the other problem is that there was no blinded randomization in many centers, not all, but women were first examined and then allocated. And one technologist at one center in Toronto directly witnessed nurse examiners allocating women into the mammography arm because they had a new clinical finding. And if we look at the actual data, there was, although well matched for all features of marital status and ethnic origin and so on, there was a big imbalance of advanced cancers where women were with advanced cancer defined by over 4 lymph nodes in the axilla were twice as more likely in the mammography arm as in the usual care arm. So it's not surprising that the breast cancer mortality in the CNBSS was 1.4 times higher in the screening arm than the usual care. Here are the numbers, and you can see in orange as the screening arm and in black and blue the usual care arm. Look at the number of women with advanced cancers. 1 in 4 advanced cancers in the first year of screening in the screening arm, as opposed to 8% in the usual care. And if we look overall, 16% total advanced cancers in the screening arm as compared to 8% in the usual care arm. It's been shown by one of my co-authors, Dr. Martin Yaffe, that just simply moving 1 or 2 women from one arm to the other can affect the mortality reduction and go from an excessive mortality reduction if we have too many in the screening arm at 1.36. By moving just a few women, 7, we can shift that benefit, that excess mortality to a reduction in breast cancer mortality. And this is the effect overall by moving 10 women from this screening arm, from the usual care arm into the screening arm. You can see that overall benefit changes to an excess of mortality. So the other problem with the study is that the quality of the mammography was very, very poor. And this is the example of the mammogram on your left from the CNBSS as compared to one from Dr. Tabar's study at the same time in Sweden. The equipment was old, and it's been shown that over 50% of the mammograms were of unsatisfactory quality in the CNBSS, and it only improved in the final 2 years. So if we look for women in the UAE, almost 40% of all cancers occur are due to breast cancer. And women from Arab origin have an onset that's 10 years earlier than women in Western countries. If we look, the median age at diagnosis is 48 years, and 2/3 of women with breast cancer are younger than 50 years in Arab populations. In fact, 1 in 5 women are between the ages of 30 and 40 years of age. So it's a different onset. And if we look at the US data, the blue markers are women in white, and you can see that their peak onset of breast cancer is in their 60s, whereas women of Black and Asian and Hispanic origin they peak below the age of 50. And if we look at the UAE, we can see that most women are diagnosed, more than half are diagnosed under the age of 50. And so doing age-based screening guidelines does not serve women well, particularly in the UAE. And if we look at Canadian data, we have a large observational trial of over 2.8 million women. We can see that looking at women who are screened in their 40s, as opposed to their 50s and 60s and 70s, there is a 44% reduction in breast cancer mortality for women in their 40s in Canada alone. Imagine how much better it would be if we look at the Arab population. We know that there's a significant benefit with early stage, not only in terms of survival, but also in lower treatment and less intensive treatment. And we want to avoid these terribly debilitating effects of treatment when we diagnose them at a later stage. So overall recommendations is that women should be considered for screening starting at age 40 years of age. And in the UAE, we should be considered starting screening even earlier at age 30. And it's very important that as healthcare professionals to be aware of the reasons and evidence in support of these recommendations. Thank you so much for your attention.
Thank you so much, Jean. This is an excellent overview of what screening for breast cancer can be and what are the pitfalls where, you know, we built a lot of policies based on the Canadian study. So I'm glad that you were able to highlight some of the ethical dilemmas there and great insight on Arab breast cancer screening. Thank you. Moving on for Karen Perry, and now she's going to give us the perspectives of nurses, especially from chemotherapy point of view. Go ahead, Karen, and thank you.
Good morning, everyone. Thank you very much. I'm very grateful to be here with everyone today. I will be presenting some ethical considerations from a nursing perspective in the systemic therapy suite. So some of the key learnings is that we're going to learn how nurses can appreciate the conflict of values and how it creates those ethical issues. We're going to be able to predict common nursing situations, apply an ethical framework, and reflect on the impact of these situations on nurses. So conflict really does occur when there is, or an ethical situation occurs when there's a conflict of values. And within nursing, there are core values that guide our practice. And so when two or more of these values are applied to a situation, but these values support a divergent course of action, an ethical situation or a dilemma then occurs. So I'm just going to go through the top four. And so the first one is when medical treatment extends life without considering the quality of life. There are times when the hope of a cure or remission is presented within a situation rather than giving hope without giving an over-optimistic scenario. So this is where we reflect truthfulness. It's the provider's responsibility to understand that it's the extension of life may not be the right option. And so this is about having respect for life. And how we can bridge this in the systemic therapy suite is knowing the patient's goals of care so that we can continue to advocate for their client choice. Second one is disparities in the wishes of the patient and the family. We see this a lot where the patient, again, they're the primary driver behind their treatment decisions, and that again reflects their client choice. But there are times when there is a difference between what the family wants, what the patient wants, and that comes back through into client well-being. And that can happen, especially when the client has become incapacitated, that the family will then start to want to have a different goal for the patient's treatment. And it's at this point where it is the nurses and all healthcare providers' responsibility to maintain those commitments to the client to make sure that their wishes are advanced. And sometimes that does mean going against the wishes of the family. This one I struggled with a little bit. It's about caring for patients who make risky decisions. And I say I struggle only because it sounds judgy. Like we are making a judgment that the decision that the patient is making is risky. But we also understand that patients want to find the best possible treatment for their conditions. And that sometimes that those treatments that they feel is best for them might be outside of traditional therapy, and they're seeking alternative therapies. And that going against the recommendations of their care providers. Again, this is the client's well-being. This is what they feel that they need to do for themselves. So even when a patient has decided to seek alternative therapies, and then they come back into the system, then that's their choice. And we have a responsibility to respect for their life. And I've had this situation where I've had a woman who was adjuvant breast cancer, felt she didn't want to receive adjuvant chemotherapy and chose to go to Mexico for curative treatment there using alternative medicines. She came back into the unit about 18 months later, and she was palliative at that point. And again, about respect for life and respect for her choice. It doesn't matter when she comes in or how she comes in, the lack of judgment is there to make sure that we are still advancing her needs and care. The big one that I see in the systemic therapy suite, and this is what I want to talk a little bit more about, is out-of-pocket expenses. And these out-of-pocket expenses is not a lot of evidence in the literature. There's becoming more in the last few years within the nursing literature frame that we're discussing what out-of-pocket looks like for patients and how it creates disparities. And so this goes back to the core value of fairness within nursing. And I've also seen where patients have not been told of certain therapies because it's known to the provider of cost prohibitive to the patient. And so that's a conflict within truthfulness. So a situation that I've experienced quite frequently, actually, and within our breast cancer population is cold therapy for patients who need who will use cold caps and gloves for hair protection and nail changes. Again, there's some evidence in the literature that suggests that it can work part of the time, depending on the individual, but it's not all of the time for all individuals. And it's not covered jurisdictionally within Ontario through our publicly funded provincial program, nor is it often funded within many private insurers, so it is an out-of-pocket expenses. And I've seen it where I have two patients side by side in the chemo suite. One has a cold cap on and the gloves, and the other does not. And this one I find is very difficult to navigate through because it's financial. And sometimes within organizations, this can be bridged by using patient supports through the foundation and staff fundraising that occurs. And out of pocket also even is parking. So that can create a lot of disparity for patients too. And how I frame this and how I navigate through my ethical dilemmas is I use a framework, and I use the duty framework. And this one really talks about treating everyone equally with dignity and respect, and following on those moral rules regardless of the outcome. And it really works best when there are situations of obligation. And in healthcare providers, this is us. We have a sense of obligation to present a safe, well-being environment for our patients. The limitations of it is it can be cold, it can be impersonal. It's also a little rigid, that it doesn't, that the notion of duty to everyone regardless of their personal situation, because situations are different and it's difficult to always have a single framework that aligns to one. And as these ethical categories come along, we have moral uncertainty and moral dilemma and moral suffering, and they just build on top of one another. And what that then ultimately ends up becoming is it has an impact to nursing and also to all healthcare providers, where you feel that ethical uncertainty when you're facing it, that you're unsure of how your values apply, and sometimes even if there is a moral problem. And when you have these considerable and constant ethical issues, is creating distress. Do you know what you want to know? You want to do the right thing, but sometimes there are constraints that allowing to do the right thing is difficult. And those constraints can be policies within the organization. It could be structures, it could be financial barriers. And these events can lead to burnout, and burnout leads to exiting the profession. A recent publication indicates that 11% of nurses are seriously considering leaving the profession. And that will have a dramatic impact on healthcare systems across the globe, as they're already fragile from the pandemic. And if nurses and all healthcare providers continue to leave the profession, there will be a substantial impact on care for patients. Thank you very much. And I'll pass it back to you, Rola.
Thank you so much, Karen. This is amazing and great insights. And I loved how you, toward the end, you really raised a very important point, how ethical dilemmas can lead to burnout. And this is what we are all faced with at global level, like the healthcare professionals are burnt out, and we are losing technologists and nurses and even some physicians very early on, before even the retirement age, just because, you know, the crisis and the ethical dilemmas. Okay, with that, I'd like to thank the wonderful speakers for sharing their insights, and we're going to move on to the questions and answers session. Thank you, everybody.